Welcome to the RPFT prep course. We are about to begin a rigorous journey to mastering the clinical and technical competencies required for your certification. This course is for informational and educational purposes only and should not be taken as medical advice. This is an unofficial, independently produced prep course and is not affiliated with, endorsed by, or connected to the National Board for Respiratory Care, NBRC, in any way. All trademarks belong to their respective owners. This course is designed to be your primary roadmap for the NBRC Registered Pulmonary Function Technologist examination. We have structured the material to mirror the official exam blueprint, ensuring you are not just memorizing facts, but building a functional mental model of pulmonary physiology and instrumentation. By committing to this curriculum, you gain a structured approach to complex diagnostic concepts that often challenge even experienced clinicians. This investment of your time will yield a clear advantage in navigating both the theoretical and clinical sections of the board exam. The path to registration involves understanding the structural nuances of the exam, including the weighting of questions across categories like equipment calibration, procedure performance, and data interpretation. You will learn how the NBRC evaluates candidates, shifting from basic recall to the application of technical data in a clinical environment. Eligibility pathways often create confusion, so we will clarify how your professional background maps to these credentialing requirements. We will also focus on developing efficient study habits that optimize your retention of dense technical information, ensuring you can manage the time constraints inherent in a high-stakes exam setting. Clinical relevance is the heartbeat of this credential, and we will emphasize professional expectations throughout every module. You must be prepared to articulate the why behind every calibration, maneuver, and data analysis step required in a modern PFT lab. We begin by helping you conduct a strategic self-assessment, identifying your current knowledge gaps so you can balance your preparation time effectively. You should aim to treat these lessons as an extension of your daily practice, constantly correlating equipment function with patient outcomes. This clinical mindset will serve you well when you finally sit for the exam. I look forward to working through these complex topics with you. I will see you in the next lecture. Welcome back. Today, we begin our chapter on respiratory system structures and mechanics, where we explore the complex anatomical and mechanical foundations of pulmonary function. By mastering these concepts, you will gain the specialized knowledge necessary to pass your board exam and excel in clinical diagnostic environments. Understanding the architecture of the respiratory system requires us to look beyond basic labels and examine the specific mechanics of airflow and structural expansion. We start with the upper airway, which serves as the primary gateway for conditioning inspired air. As air transitions into the lower airways, specifically from the trachea down through the conducting zone of the bronchi and bronchioles, we see a systematic reduction in cross-sectional diameter that influences resistance. The transition from these conducting airways to the respiratory zone involves the alveolar capillary network, where the structural configuration is optimized for rapid gas diffusion. We must view this as a dynamic system where the chest wall, including the ribcage and the diaphragm, acts as an external bellows generating the essential pressure gradients. These gradients are maintained by the pleural space, where the negative pressure relative to atmospheric pressure keeps the lung parenchyma opposed to the thoracic wall during cyclic ventilation. The physics governing these structures often revolves around the delicate balance of elastic recoil and surface tension. Surfactant, secreted by type II alveolar cells, serves as a critical mechanical modifier that reduces surface tension at the alveolar air-liquid interface. Without this surfactant, the work required to inflate the lungs would be exponentially higher due to the high recoil forces of the curved fluid surface within the alveoli. When we analyze compliance, we are essentially measuring the volume change per unit of pressure change, which shifts predictably in various disease states. For instance, in fibrotic conditions, the lung tissue becomes stiff, requiring higher pressures for smaller volume changes, effectively lowering compliance. Conversely, in emphysema, the loss of elastic tissue increases compliance but compromises the structural integrity needed to keep small airways patent during exhalation. Resistance to airflow is a fundamental variable that we calculate based on the geometry of the airway generations and the nature of the gas flow. Poisson's law governs much of this. highlighting that even minor reductions in the radius of an airway can lead to a significant, nonlinear increase in resistance. As technologists, it is vital that we recognize how structural limitations manifest during laboratory maneuvers, such as the early airway closure seen in patients with obstructive pathophysiology. We also need to assess respiratory muscle function, particularly looking for patterns of diaphragmatic fatigue. If the diaphragm, the primary muscle of inspiration, fails to meet the metabolic demand, we observe changes in breathing patterns that often precede respiratory failure. Correlating these mechanical inefficiencies with our visual data from flow volume loops allows us to construct a complete clinical picture for the physician. The interplay between the chest wall and the underlying parenchyma is not merely a passive relationship, but a highly regulated mechanical system. When we look at pleural pressure gradients, we realize they are not uniform across the vertical axis of the lung due to gravity. The weight of the lung itself causes slightly higher alveolar pressures at the base compared to the apex in an upright individual. This structural variance influences regional ventilation and perfusion, which we see manifested in the data we collect during advanced pulmonary assessments. Mastering the mechanics of these structures will ensure you are prepared to identify errors in diagnostic maneuvers caused by physical patient limitations. Precision in our understanding allows us to distinguish between structural mechanical failure and physiological gas exchange dysfunction effectively. Proceed to the next module for further study. Welcome back. We are now turning our technical focus toward the underlying physics and chemistry that enable gas exchange within the lung. In this chapter, we will master the mechanics of diffusion, hemoglobin dynamics, and the precise calculations required to interpret oxygenation capacity at the alveolar capillary membrane. To understand how gas moves from the alveoli into the blood, we must begin with Fick's law of diffusion, which dictates that the rate of gas transfer is proportional to the surface area and the partial pressure gradient, while inversely proportional to the thickness of the membrane. In a healthy lung, the alveolar capillary membrane is incredibly thin, often less than a micron, facilitating rapid equilibration of oxygen and carbon dioxide. When this membrane thickens, perhaps due to interstitial fibrosis or pulmonary edema, the diffusion distance increases, leading to a measurable decline in gas transfer efficiency. We quantify this transfer using the diffusing capacity of the lung for carbon monoxide, as its high affinity for hemoglobin makes it an ideal marker for evaluating the functional surface area available for gas exchange. Understanding these physical barriers allows you to distinguish between ventilation-perfusion mismatches and actual diffusion limitations, which is a common diagnostic distinction in the clinical laboratory. Once oxygen crosses the membrane, it relies primarily on hemoglobin for systemic transport, a process governed by the oxyhemoglobin dissociation curve. The affinity of hemoglobin for oxygen is not constant. It shifts in response to environmental conditions within the tissue, a phenomenon known as the Bohr effect. When tissues are metabolically active, they produce carbon dioxide and hydrogen ions, which lower the local pH and decrease hemoglobin's affinity for oxygen, thereby promoting oxygen unloading where it is needed most. Conversely, the Haldane effect describes the inverse relationship, where the removal of oxygen from hemoglobin in the tissues improves the blood's capacity to transport carbon dioxide back to the lungs. This delicate chemical dance ensures that cellular respiration proceeds efficiently despite fluctuations in systemic demand. And as a technologist, you must recognize how abnormal hemoglobin states interfere with this balance. Carboxyhemoglobinemia and methemoglobinemia are perfect examples of how competitive binding and structural alterations can render hemoglobin incapable of effective oxygen delivery. Carbon monoxide binds to hemoglobin with an affinity roughly 200 times that of oxygen, effectively locking the sites and shifting the dissociation curve to the left, which prevents oxygen release at the tissue level. Methemoglobin, on the other hand, occurs when the iron atom in the heme group is oxidized from a ferrous state to a ferric state, preventing oxygen binding altogether and creating a scenario of functional anemia. In these cases, standard pulse oximetry often provides misleadingly high readings because the device cannot distinguish between functional oxygenated hemoglobin and these deshemoglobin species. To accurately assess the situation, you must rely on advanced co-oximetry, which isolates the specific absorption spectra of each hemoglobin variant. Carbon dioxide transport is equally complex, as it moves through the bloodstream as dissolved gas, bound to hemoglobin as carbaminohemoglobin, and most significantly, as bicarbonate ions. The conversion of carbon dioxide to bicarbonate is facilitated by the enzyme carbonic anhydrase within the red blood cells, which prevents an immediate rise in acidity during transport. As bicarbonate concentrations rise inside the cell, it is exported into the plasma in exchange for chloride, a fundamental process known as the chloride shift. This mechanism provides a crucial buffering capacity for the blood, maintaining homeostasis until the blood reaches the pulmonary capillaries. You will frequently observe these interactions when analyzing blood gas data, where the interplay between partial pressures, pH, and hemoglobin saturation provides a complete picture of a patient's respiratory health. Finally, we use the alveolar to arterial oxygen gradient to bridge the gap between theoretical lung function and the reality of a patient's arterial status. By calculating the difference between the partial pressure of oxygen in the alveoli and the arterial blood, we can isolate whether hypoxemia is caused by lung-specific gas exchange issues or external factors like hypoventilation. A widened A gradient strongly suggests that the problem exists at the interface where air meets blood, such as in cases of diffusion impairment or significant shunting. Calculating this gradient is a standard procedure in clinical interpretation, and it requires precision in measuring the fraction of inspired oxygen and the patient's barometric condition. Mastering these equations will ensure your diagnostic conclusions reflect a deep, principled understanding of human physiology. I'll see you in the next lecture. Welcome to this session on ventilation and perfusion relationships, where we will build a robust understanding of VQ dynamics to master the complexities of gas exchange. To understand the mechanics of gas exchange, we must first look at the lung, not as a uniform bag, but as a gravitationally dependent system known as West zones. In a healthy, upright lung, blood flow is lowest at the apex and highest at the base due to hydrostatic pressure effects, while ventilation also increases toward the base, but at a slower rate than perfusion. This creates a vertical gradient of the ventilation-perfusion ratio, often referred to as the VQ ratio, which is typically higher at the apex and lower at the base. Clinically, this means the apex is relatively overventilated compared to its blood supply, while the base is underventilated relative to its abundant perfusion. When these zones become disrupted by disease, we see the emergence of VQ mismatching or shunt, which are the primary drivers of clinical hypoxemia. Understanding this regional variation is the bedrock upon which you will interpret pulmonary function data and distinguish between different causes of respiratory failure. Physiological dead space represents the volume of gas that participates in inspiration but does not engage in meaningful gas exchange, and we quantify this using the Bohr equation. This concept is distinct from anatomical dead space, which occupies the conducting airways, because physiological dead space includes both anatomical components and alveolar dead space. Alveolar dead space arises when alveoli are ventilated but lack adequate perfusion, effectively turning functional lung tissue into a reservoir for gas that cannot participate in arterial oxygenation. By measuring the partial pressure of carbon dioxide in both arterial blood and mixed expired gas, the Bohr equation allows us to calculate the ratio of dead space to tidal volume. A rising ratio in your patient data often serves as a sensitive indicator for pulmonary vascular disease or reduced cardiac output, where capillary perfusion failures leave alveoli underutilized. Mastering this calculation is vital, as it allows you to identify when a patient is working harder to breathe without seeing a commensurate benefit in gas exchange efficiency. The clinical management of severe hypoxemia often requires us to differentiate between simple VQ mismatching and a true right-to-left shunt. A useful tool here is the 100% oxygen breathing challenge, which helps to isolate the source of persistent low arterial oxygen saturation. In a case of VQ mismatch, providing high concentrations of inspired oxygen can eventually facilitate the diffusion of oxygen into poorly ventilated alveoli, causing the arterial oxygen tension to rise significantly. Conversely, in a true anatomical or physiological shunt, blood bypasses the gas exchange units entirely, meaning that even breathing pure oxygen will not be able to raise the arterial tension toward expected levels. This distinction is mathematically captured through the shunt equation, which compares the oxygen content of pulmonary capillary blood with that of in-capillary blood. Recognizing these nuances ensures that you provide an accurate diagnosis, especially when dealing with complex pathologies like acute respiratory distress syndrome, where shunting is often the dominant mechanism. We must also consider how external factors like positive pressure ventilation and postural changes dynamically modify these perfusion configurations within the laboratory. When a patient is placed on a mechanical ventilator, the introduction of positive thoracic pressure changes the relationship between alveolar and vascular pressures, often reducing venous return and altering the distribution of pulmonary blood flow. Similarly, gravity plays a persistent role. Shifting a patient from sitting to supine reorients the hydrostatic gradients, essentially flipping the West zones and changing the regional matching of ventilation and perfusion. Furthermore, the lung demonstrates a compensatory mechanism known as hypoxic pulmonary vasoconstriction, where blood flow is shunted away from poorly ventilated regions to better functioning areas to optimize overall oxygen uptake. As a technologist, you will be observing these shifts during testing, and you must understand that the data you see is not static, but rather a snapshot of a highly adaptive biological system responding to both the patient's condition and the environment of your testing equipment. See you in the next lecture. Welcome back to the course. In this lesson, we will begin our exploration of acid-base balance and regulation, focusing on how the body maintains homeostatic pH ranges. Maintaining systemic pH within the narrow window of 7.35 to 7.45 is a critical physiological requirement for enzyme function and cellular signaling. The body achieves this stability through a hierarchy of buffer systems that act almost instantaneously, followed by respiratory and renal adjustments that provide long-term control. The bicarbonate buffer system is our primary focus because it is open-ended, meaning it can be regulated by both the lungs and the kidneys, unlike closed systems that are strictly limited by their concentration in the blood. The relationship between pH, bicarbonate, and partial pressure of carbon dioxide is elegantly described by the Henderson-Hasselbalch equation, which illustrates why moving from a ratio of 20:1 bicarbonate to carbonic acid results in significant shifts in clinical health. As a pulmonary function technologist, you will need to visualize these components not as abstract symbols, but as active variables that shift depending on the patient's ventilation status or metabolic demand. When a patient hyperventilates, they purge CO2, dropping their PCO2 levels and causing the equilibrium to shift toward alkalinity. Conversely, hypoventilation leads to CO2 retention and a drop in pH, which the body initially attempts to stabilize through chemical buffering before the lungs or kidneys can fully intervene. Understanding these transitions is the baseline for interpreting arterial blood gas results in any clinical setting. Once the immediate buffering capacity is taxed, the respiratory system serves as the first line of active physiological correction for metabolic imbalances. The peripheral and central chemoreceptors are acutely sensitive to shifts in pH and PCO2, triggering feedback loops that alter the depth and frequency of breaths to restore balance. If you are examining a case of metabolic acidosis, you will notice the classic Kussmaul breathing pattern where the body attempts to blow off CO2 to effectively increase the pH toward neutrality. However, the respiratory response is limited. It can act fast, but it can also be easily exhausted or constrained by underlying lung disease. When the respiratory system cannot maintain the pH, the renal system takes over, albeit over a much longer time frame. The kidneys do this by reabsorbing filtered bicarbonate or excreting hydrogen ions into the urine, which is a slow process that might take several days to reach maximal effectiveness. This dichotomy between acute respiratory compensation and chronic renal adaptation is precisely what you must identify when analyzing complex blood gas reports. A patient with chronic obstructive pulmonary disease, for instance, may present with high bicarbonate levels that act as a chronic compensation for their baseline respiratory acidosis. Distinguishing between primary and secondary insults requires a systematic evaluation of all blood gas parameters rather than looking at pH in isolation. We look for the primary disorder by identifying the underlying shift in PCO2 or bicarbonate. Then we evaluate the presence of compensation to determine if the body has successfully recalibrated or is still struggling to maintain homeostasis. The plasma anion gap is an essential tool in this analysis, as it allows us to differentiate between metabolic acidosis caused by the loss of bicarbonate versus the addition of unmeasured pathologic acids. In a clinical environment, Calculating the anion gap helps flag conditions like ketoacidosis, lactic acidosis, or toxin ingestion that would otherwise be hidden in a standard electrolyte panel. You should also be prepared to recognize mixed acid-base disorders, where both metabolic and respiratory mechanisms are deranged simultaneously. For example, a patient might have both a metabolic acidosis from sepsis and a respiratory alkalosis from early ventilator support or high-altitude exposure. By mastering the expected compensatory patterns, you can identify when a laboratory value is inconsistent with the patient's clinical state and catch errors or progression in the disease process early. In the next segment of this course, we will apply these concepts to real-world clinical data. See you in the next lecture. Welcome to this exploration of pathophysiologic pulmonary states, where we will build the foundation for interpreting complex lung disease. We will examine the specific mechanics and cellular drivers behind obstructive and restrictive airway disorders. To understand the spectrum of obstructive lung diseases, we must first focus on the degradation of the lung periphery in conditions like emphysema and the inflammatory cycles seen in chronic bronchitis. Emphysema is characterized primarily by the permanent enlargement of air spaces distal to the terminal bronchioles, which occurs due to the destruction of alveolar walls. This destruction stems from the loss of elastic recoil, as the delicate elastin fibers in the alveolar septa are broken down by an imbalance of protease and antiprotease activity. When these supporting structures vanish, the radial traction that normally keeps small airways open during expiration is lost, contributing to the characteristic air trapping and hyperinflation seen on lung volume tests. Conversely, chronic bronchitis involves a hypersecretion of mucus coupled with hypertrophied bronchial glands, leading to an obstruction of the peripheral airways from the inside out. Unlike the parenchymal destruction seen in emphysema, bronchitis primarily affects the conducting architecture, often leading to distinct ventilation-perfusion mismatches and hypoxemia. When evaluating these patients, you must look for the classic sign of increased residual volume and functional residual capacity, reflecting the air that simply cannot be exhaled due to this loss of elastic recoil and airway narrowing. Asthma and cystic fibrosis represent distinct pathways of architectural distortion and airway hyperresponsiveness that require a sharp eye during diagnostic testing. In asthma, we are dealing with a reversible airway obstruction that is frequently mediated by bronchial smooth muscle contraction, mucosal edema, and cellular infiltration. The airway remodeling that occurs over years of poorly controlled inflammation often results in fixed or semi-fixed obstruction, which complicates the differentiation from irreversible conditions like chronic obstructive pulmonary disease. Cystic fibrosis, by contrast, creates an obstructive pattern through the chronic accumulation of thick, tenacious secretions that plug the airways and promote recurrent infections. These repeated insults lead to bronchiectasis, which is the permanent, abnormal dilation of the bronchi, causing further distortion of the lung morphology and significantly worsening the work of breathing. When performing tests, you will likely encounter a mixed clinical picture in these patients, where lung volumes may be increased due to gas trapping, but the diffusing capacity could also be impacted by secondary interstitial damage related to chronic inflammation. Understanding these cellular mechanisms helps you anticipate why certain patients achieve high flows during bronchodilator response, while others remain constrained by structural damage. Restrictive processes require us to shift our analytical framework toward lung compliance in the stiffness of the respiratory system, whether that involves the parenchyma or the chest wall. Idiopathic pulmonary fibrosis represents the quintessential parenchymal restrictive disease, where progressive scarring alters the lung architecture, significantly reducing lung compliance. As the alveoli are replaced by fibrous tissue and interstitial thickening, the lungs become less able to expand, which explains the characteristic decrease in total lung capacity, residual volume, and vital capacity. Sarcoidosis introduces a different variety of architectural distortion through the formation of non-casseating granulomas, which can impede lung function through both space-occupying lesions and fibrotic healing processes. We must also distinguish these parenchymal changes from chest wall deformities, such as kyphoscoliosis or severe obesity, which limit the expansion of the thoracic cage. In chest wall restriction, the lungs themselves may be healthy, but the mechanical system limiting their volume prevents the patient from reaching predicted ventilatory capacities. By carefully correlating the reduction in lung volumes with the appearance of the flow volume loop, you can distinguish between these disparate causes of restriction. Parsed within these clinical pictures are complex vascular abnormalities that often complicate our interpretation of primary lung disease. Pulmonary hypertension is a frequent secondary complication, particularly in advanced chronic obstructive pulmonary disease and interstitial lung disease, driven by both hypoxic pulmonary vasoconstriction and the loss of the pulmonary capillary bed. When the capillary bed is destroyed in emphysema or compressed by fibrotic tissue, the resistance to blood flow increases, forcing the right ventricle to generate higher pressures. This vascular remodeling can eventually lead to right-sided heart failure, a process that further degrades the patient's exercise tolerance and gas exchange efficiency. As technologists, identifying the presence of pulmonary hypertension requires you to look beyond standard spirometry and volumetric data toward parameters like the diffusing capacity. A disproportionately low diffusing capacity relative to the lung volumes often indicates a decrease in the available surface area for gas exchange, which can strongly hint at vascular involvement in the parenchymal disease process. Recognizing these relationships allows for a more holistic view of the patient's condition beyond simple obstructive or restrictive patterns. See you in the next session. Welcome to this chapter, where we shift our focus towards synthesizing raw diagnostic data into a cohesive understanding of clinical patient presentation. We will bridge the gap between individual metrics and the broader physiological reality of the patient. In this session, we examine how to correlate fragmented laboratory data with mechanical and physiological clinical markers. As a technologist, you often possess a table of values that, in isolation, might look unremarkable or contradictory. The true skill lies in linking low diffusion capacity or mechanical restriction to the patient's observed baseline parameters. For instance, if a patient presents with a diminished total lung capacity, we must immediately verify this against their airflow obstruction markers to determine if the restriction is purely parenchymal or secondary to hyperinflation. We are essentially building a diagnostic mosaic where every piece of data must fit the patient history perfectly. By evaluating gas exchange metrics alongside mechanical impedance, we can rule out measurement errors that often plague poorly executed tests. It is not merely about hitting a button on a plethysmograph. It is about questioning why the numbers look the way they do in the light of the patient's clinical symptoms. When we transition to metabolic testing, the challenge becomes distinguishing between cardiac and pulmonary limitations. During exercise, many patients experience dyspnea, but the physiological trigger for that distress can vary wildly, depending on the underlying pathology. If we see early anaerobic threshold arrival followed by a plateau in oxygen consumption that occurs alongside a preserved breathing reserve, our attention must shift toward cardiac limitations. Conversely, if the patient reaches their maximal voluntary ventilation before they hit their peak oxygen consumption, we are looking at a pulmonary limited distress state. This differentiation is the hallmark of an advanced practitioner who understands that the respiratory system does not operate in a vacuum. We use the respiratory exchange ratio as a guide to determine the level of patient effort, which confirms whether the physiological data we are seeing represents a true cardiopulmonary limit or a suboptimal testing performance. Synthesizing this multifaceted data requires a systematic approach to establishing physiological frameworks for every diagnostic summary. We start by confirming that our baseline testing conditions were safe and within expected limits, ensuring that the patient's stability justifies the stress of the procedure. Once we have confirmed the validity of the data, we look for harmony between the gas exchange performance and the structural capacity of the lungs. If a patient shows severe airway obstruction, we should logically expect a correlating impact on the forced expiratory volume and a potential shift in the ventilation-perfusion relationship. By mapping these markers back to the patient's primary clinical complaint, we avoid the trap of treating the numbers on the screen rather than the human being in the chair. Ultimately, your documentation should reflect a complete physiological narrative that is not only accurate, but also diagnostic in its clarity and depth. I will see you in the next lesson. Welcome back, and let's dive into the core mechanics of how your PFT hardware actually functions. In this lecture, we will examine the engineering behind spirometry devices, distinguishing between volume displacement systems and flow sensing technology. Volume displacement spirometers were the historical gold standard, relying on the physical movement of a gas collecting container to measure exhalations. The water seal spirometer functions by utilizing an inverted bell floating in a water-filled chamber, where the patient's exhaled gas physically lifts the bell, providing a direct measurement of volume. While incredibly accurate due to its lack of mechanical friction, these units are largely absent from modern high-throughput laboratories due to their bulky nature and strict maintenance requirements. Bellows-type spirometers use a collapsible, accordion-like structure that expands as volume is added, providing a simple mechanical method to record displacement. The rolling seal spirometer improves upon this by using a piston paired with a lightweight plastic seal, providing low resistance while maintaining high precision. These displacement designs are inherently stable, but they require meticulous cleaning to prevent contamination or seal degradation that could otherwise lead to inaccurate volume readings. Flow sensing devices, or pneumotachometers, represent the modern standard by measuring the velocity of gas rather than total volume. The Fleisch pneumotachometer operates on the principle of a resistive element, usually a series of small, parallel capillary tubes that create a laminar flow restriction. By measuring the pressure drop across this resistive element, the system calculates flow rate based on Poiseuille's law, which is then integrated over time to derive volume. A Lilly pneumotachometer functions similarly but uses a fine mesh screen to create the resistance, which is often more compact than the capillary bundles found in Fleisch devices. Both systems suffer from sensitivity to water vapor and condensation, which can clog the screen or capillaries and significantly skew resistance calculations. Proper maintenance of these mesh surfaces is critical, as any accumulation of sputum or moisture changes the fluid dynamics and immediately compromises the accuracy of the integration. More advanced techniques include ultrasonic and thermal wire flow sensors, which operate outside the constraints of traditional differential pressure sensing. Ultrasonic spirometers measure the flight time of high-frequency pulses moving both with and against the flow of exhaled air, where the difference in transit time is directly proportional to gas velocity. This method is advantageous because it is immune to changes in gas composition and requires minimal resistance, which is ideal for pediatric or elderly patients who may struggle with higher resistance systems. Thermal wire anemometry uses a heated wire maintained at a constant temperature. The flow of air cools the wire, and the power required to keep the temperature constant serves as a measure of the flow rate. While these sensors offer excellent response times, they can be sensitive to rapid temperature fluctuations that are inherent in the delivery of warm, humidified expiratory gases from the lung. Regardless of the sensing method, all spirometers must account for the physical state of the gas as it transitions from the patient into the device. We must always perform a BTPS correction, which stands for body temperature, pressure, and saturated water vapor, as gas measured at room temperature, ATPS, is always smaller in volume than the same gas at body temperature. Because the lung environment is warm and fully saturated, the gas expands when it leaves the mouth, and failing to apply this conversion factor would lead to a significant underestimation of the patient's actual lung volumes. Furthermore, software-level processing, such as back extrapolation, is essential for defining the start of a forced expiratory maneuver. By identifying the point of steepest rise in volume and extending it back to the intersection with the volume axis, we can determine time zero, effectively ignoring hesitant starts or minor artifacts during the initiation of the test. The precision of your diagnostic data is ultimately limited by the system's digital resolution and sampling rate. If a device has a slow sampling rate or insufficient bits of resolution, the software cannot accurately capture the rapid peak flows seen at the very beginning of a healthy FVC maneuver, leading to a jagged or artificially smooth flow volume loop. Frequency response is another critical hardware parameter, as the transducer must be capable of reacting to the rapid onset of flow without significant mechanical lag or systemic overshoot. Modern systems integrate these mechanical signals using microprocessors that operate at high frequencies. But the physical constraints of the transducer, such as the turbulence in a pneumotach, remains the fundamental limit on accuracy. When you oversee these tests, you are supervising a complex interplay between fluid physics, electronic transduction, and algorithmic correction, all of which must be perfectly aligned to produce a valid diagnostic output. See you in the next lecture. Welcome back. We are now turning our technical focus toward the underlying mechanics of body plethysmography. We will examine the operational principles and physical constraints that allow us to calculate thoracic gas volume and airway resistance with precision. At the core of all body plethysmography resides the physical manifestation of Boyle's law, which dictates that the volume of a gas is inversely proportional to its pressure at a constant temperature. In a constant volume variable pressure plethysmograph, the patient sits inside a rigid enclosure while the box pressure is monitored as the patient makes respiratory efforts against a closed shutter. As the patient attempts to inspire against this closed airway, the thoracic gas volume expands, causing the lung pressure to decrease and the box pressure to increase accordingly. We essentially treat the entire body as a displacement device, where the expansion of the chest wall compresses the air inside the chamber. The transducer sensitivity required for these measurements is significant, as the fluctuations in box pressure are often minuscule compared to atmospheric pressure. Consequently, the hardware must be meticulously designed to maintain isothermal conditions, as any heat transfer during the compression or expansion cycles would violate the assumptions inherent in Boyle's law. To ensure these pressure changes are captured accurately, we must account for the mechanical influence of the shutter system itself. The closing of the airway shutter at the end of a normal expiration allows us to measure the thoracic gas volume at the functional residual capacity level. However, the shutter mechanism must operate with near instantaneous response times to prevent artifacts caused by the patient involuntarily adjusting their breathing pattern during the brief occlusion. Furthermore, we must address the thermal stabilization of the air inside the box, because heat dissipation from the patient's body can introduce significant baseline drift. We achieve this stability through deliberate material selection and sophisticated electronic compensation circuits that neutralize the signal baseline. Without this thermal management, the pressure transducer would respond to convection currents rather than genuine thoracic volume changes, leading to clinical inaccuracies. When we transition to the calculation of airway resistance, the complexity of signal processing becomes even more pronounced. Airway resistance requires measuring the relationship between flow at the mouth and the alveolar pressure changes derived from the box pressure. One of the major technical hurdles here is the phase alignment between the flow transducer and the box pressure transducer, as any lag between these two channels will distort the resulting pressure flow loop. Engineers use anti-aliasing filtering and digital signal processing to ensure that the timing of these signals remains perfectly synchronized, even at high respiratory frequencies. These systems must also account for the inherent box volume constraints, as the total volume of the chamber influences the magnitude of the pressure swing generated by the patient. If the volume of the box is not precisely calibrated, or if the electrical sensors show signs of drift, the calculated resistance values will diverge from actual physiologic performance. Precision in plethysmography is ultimately a result of managing hardware limits and environmental variables simultaneously. The electrical calibration of these devices is not a one-time process, but a continuous requirement to ensure the transducer signals represent actual physical displacement. We must treat the plethysmograph as an integrated system, where the limitations of the enclosure, the sensitivity of the pressure transducers, and the fidelity of the software filters all play a part in the final diagnostic output. Errors in these systems are rarely catastrophic failures. They usually manifest as subtle inaccuracies in volume readings that can misguide clinical interpretation of obstructive or restrictive patterns. By understanding how the physics of gas behavior intersects with electrical engineering, you gain the ability to troubleshoot these systems properly when results deviate from expected norms. Mastering these technical nuances allows you to stand behind your data with complete diagnostic confidence. I will see you in the next lecture. Welcome back. We are diving into the technical heart of laboratory equipment by examining the specific mechanics of gas analyzers and sensors used in modern pulmonary function suites. Infrared absorption analyzers serve as the backbone for measuring carbon monoxide and methane, operating on the fundamental principle that these gases absorb electromagnetic radiation at specific wavelengths. The device uses a broad-spectrum light source passed through a sample cell, where the target gas molecules vibrate and absorb photons proportional to their concentration. A chopper wheel is essential in this configuration, as it periodically interrupts the infrared beam to create a pulsed signal, allowing the detector to distinguish between the static light source and the dynamic absorption changes. An internal reference cell, shielded from the sample gas, helps the system compensate for fluctuations in light source intensity or optical misalignment over time. One critical aspect of this technology is sample conditioning. As water vapor shares infrared absorption bands with the gases we measure, we typically employ diarite, an anhydrous calcium sulfate, or specialized Nafion tubing to strip moisture from the sample gas stream, ensuring that our readings remain accurate and free from humidity-induced interference. Thermal conductivity analyzers provide a robust method for measuring helium concentrations, relying on the principle that different gases dissipate heat at distinct rates. These sensors usually consist of a Wheatstone bridge circuit, where heated filaments are exposed to the sample gas and a reference gas, such as room air. Since helium has a significantly higher thermal conductivity than nitrogen or oxygen, the presence of helium cools the filament more rapidly, creating a measurable imbalance in the electrical circuit. When designing these systems, technologists must account for the specific sampling flow rate, as the cooling effect is highly dependent on the velocity of the gas passing over the sensor. You should keep in mind that these sensors are sensitive to gas temperature and composition changes, making them susceptible to drift if the environment is not stable. During your daily routine, you should check the linearity of the thermal conductivity signal across the expected clinical range to verify that the bridge output accurately reflects known standards, particularly when testing lung volumes. Oxygen analysis involves more complex electrochemical mechanisms, or zirconium oxide sensing, each with distinct operational demands. Electrochemical cells function much like a battery, where oxygen diffuses through a membrane and reacts at the cathode, generating a small electric current proportional to the partial pressure of oxygen. These cells have a finite lifespan defined by chemical depletion, as the electrolyte eventually becomes consumed, leading to signal degradation and unreliable readings. A primary sign of a failing sensor is a sluggish response time or an inability to achieve a proper zero baseline, which should alert you that a replacement is required. Conversely, zirconium oxide sensors operate at high temperatures, creating an oxygen ion current through a ceramic electrolyte. These sensors offer a very fast response time, ideal for breath-by-breath analysis, provided the heater maintains the sensor at the required operating temperature. You must manage cross-sensitivity issues, especially if the sample gas contains other reactive species that might influence the current flow in your sensors. Nitrogen measurement, often required in specialized nitrogen washout studies, typically utilizes emission spectroscopy or ionization-based Geissler tube systems. In a Geissler tube, a high-voltage electrical discharge is passed through a low-pressure gas sample, causing it to glow. The intensity of this light, specifically at the nitrogen excitation wavelength, is measured to determine gas concentration. This process requires precise pressure regulation within the ionization chamber to keep the spark discharge stable and consistent. You will encounter physical optimization routines that require periodic validation of the light source intensity and the integrity of the ionization window, which can become clouded by residue over time. Any analyzer drift in these systems can lead to systemic errors in ventilation distribution calculations. So maintaining the integrity of the vacuum system and the high-voltage supply is non-negotiable. Always verify that your gas sampling flow rates match the manufacturer's technical specifications, as any deviation here can invalidate the ionization mechanics and lead to spurious results. Understanding the nuances of these sensors is critical for passing the exam and performing reliable clinical work. See you in the next lecture. Welcome back. In this lecture, we will explore the underlying instrumentation physics of blood gas and oximetry systems. Precision in arterial blood gas analysis relies on electrochemical sensors that translate partial pressures into measurable electrical currents. The Clark electrode, designed for oxygen tension, utilizes a polarographic sensor where oxygen diffuses through a gas-permeable membrane to a platinum cathode. This cathode reduces oxygen in a reaction that consumes electrons, generating a current directly proportional to the partial pressure of oxygen at the sensor surface. Conversely, the SANS electrode measures pH by monitoring the potential difference across a hydrogen ion-sensitive glass membrane compared to a reference electrode. Because these chemical reactions are exquisitely temperature-sensitive, the cuvette must be strictly regulated at 37 degrees Celsius to ensure that solubility coefficients remain consistent during measurement. Failure to maintain this thermal stability introduces significant bias, as the partial pressure of gases in solution shifts predictably with temperature fluctuations according to Henry's law. The Severing-House electrode represents a sophisticated evolution of the pH electrode, adapted for carbon dioxide measurement. It incorporates a SANS-type glass electrode immersed in a bicarbonate buffer solution, separated from the blood sample by a CO2 permeable membrane. As carbon dioxide molecules diffuse through the membrane into the electrolyte layer, they react with water to form carbonic acid, which subsequently dissociates into hydrogen ions and bicarbonate. This local change in hydrogen ion concentration alters the potential across the glass electrode, which the system electronically translates into the partial pressure of carbon dioxide. Maintaining the membrane's integrity and hydration is paramount, as the drying of the electrolyte or membrane fouling effectively increases response time and degrades the signal-to-noise ratio. Precise electrical shielding is necessary throughout all these circuits to prevent the introduction of interference from the surrounding laboratory equipment. Turning to oximetry, we must understand the shift from simple infrared pulse oximetry to multi-wavelength co-oximetry. Standard pulse oximeters operate by emitting two wavelengths of light, typically 660 nanometers for red and 940 nanometers for infrared, to distinguish between oxyhemoglobin and deoxyhemoglobin based on their distinct absorption spectra. While this suffices for identifying functional oxygen saturation, it cannot resolve the presence of dyshemoglobins like carboxyhemoglobin or methemoglobin. Co-oximeters overcome this limitation by utilizing multiple wavelengths of light to perform spectrophotometric analysis across the entire hemoglobin absorption spectrum. By solving simultaneous linear equations derived from the absorbance data, the device mathematically isolates the concentrations of various hemoglobin species. This computational process is highly sensitive to ambient light interference, which the device mitigates through sophisticated algorithms, including signal modulation and subtraction of background noise. Effective operation of these systems requires an intimate understanding of the transducer optics and the underlying mathematical models. Transcutaneous pulse oximetry, while related to co-oximetry, employs local capillary heat-induced vasodilation to improve perfusion at the sensor site. The accuracy of this measurement depends upon the ability of the algorithm to detect the pulsatile component of the arterial signal, effectively filtering out non-pulsatile venous and tissue background noise. We must recognize that the performance of these sensors is contingent upon regular maintenance, specifically ensuring the optics remain clean and the electrochemical electrolyte remain adequately hydrated. These technical considerations are not merely maintenance tasks, but are instead foundational requirements for ensuring the physiological data we receive is accurate and clinically actionable. When evaluating device performance, we should consistently look for deviations in baseline stability or increased drift, as these are often the first objective indicators of component degradation. See you in the next lecture. Welcome back. In this lecture, we will begin our exploration of the various auxiliary devices and support equipment essential for a functioning pulmonary function laboratory. When we speak of pulmonary function testing, we often focus on the central hardware like the pneumaticograph or the plethysmograph. But the auxiliary devices are what actually allow these systems to interface with the patient and provide consistent data. We must understand the mechanics of demand valves, which are designed to deliver gas only during the inspiratory phase, and directional breathing circuits that rely on one-way valve systems to prevent rebreathing. The design specifications for these components are not arbitrary. They are governed by strict resistance parameters across high flows to ensure that the patient's respiratory effort is not artificially impeded by the equipment itself. If a valve has an excessively high cracking pressure, the patient must exert significantly more inspiratory muscle force just to open the mechanism, which inherently alters the resulting flow volume data and complicates the validity of your testing results. We also need to consider the physical dead space introduced by various adapters and connectors, as any additive volume in the breathing circuit effectively increases the instrumental dead space that the patient must ventilate. This contribution must be recognized and, when necessary, corrected during the data processing phase to avoid misrepresenting the patient's actual tidal volume or alveolar ventilation. Moving into aerosol delivery, we rely on nebulizers and automated dosimeters to standardize the administration of pharmacological agents, particularly during bronchial provocation challenges. The quality of a study here depends entirely on the aerosol particle sizing distribution, specifically the mass median aerodynamic diameter, which determines how deeply the particles penetrate into the peripheral airways. An improperly functioning nebulizer might produce particles that are too large, leading to significant impaction in the oropharynx rather than the target distal bronchi, thereby invalidating the provocation protocol. Furthermore, the electronic timing interfaces for these automated dosimeters must be precisely calibrated, as the duration of the aerosol delivery directly dictates the cumulative dose received by the patient. If the timing interface is off by even a few hundred milliseconds, the consistency of the testing protocol is compromised, and the diagnostic threshold for a positive provocation result becomes unreliable. Achieving accurate results requires us to treat these delivery systems not as simple accessories, but as precision instruments that require the same level of scrutiny as our primary spirometric sensors. Calibration and maintenance of these auxiliary systems are just as critical as the hardware used for patient maneuvers. Mechanical calibration syringes serve as the gold standard for verifying flow and volume accuracy, yet we must ensure they are used with appropriate connectors that do not introduce leaks or unintended resistance. When dealing with complex piping arrays, we are often forced to deal with the inherent compliance of the tubing, which expands under pressure and can lead to systematic errors if not corrected within the software's configuration. We must be diligent in performing regular mechanical integrity testing, which involves applying positive or negative pressure to a closed circuit to detect minute leaks that might only manifest under specific flow conditions. Furthermore, equipment software calibrations must be updated periodically to account for environmental factors like barometric pressure and ambient temperature, as these variables affect gas density and, consequently, the accuracy of our flow measurements. Relying on automated software checks is a good starting point, but a true professional understands the underlying physical principles, such as the relationship between gas density and pressure drops across restricted orifices, to troubleshoot discrepancies effectively when the software reports an error or, worse, provides a false positive pass. In short, mastering these auxiliary devices ensures that your laboratory data reflects the patient's physiology rather than equipment-induced artifacts. See you in the next lecture. Hello everyone, and welcome back. In this chapter, we will explore the foundational requirements for keeping diagnostic hardware functional and safe within the laboratory environment. Safety engineering in a clinical setting is not merely an administrative hurdle, but a fundamental component of obtaining reliable diagnostic data without compromising patient or staff integrity. When we examine diagnostic hardware, our primary concern involves the electrical and mechanical stability of the equipment before it ever touches a patient. Electrical leakage is a significant risk factor in any environment where conductive leads and sensors are attached to a subject who might be in a fragile physiological state. Grounding configurations represent the first line of defense against these stray currents, and you must verify that all instrumentation is connected to a hospital-grade or dedicated isolated circuit. Regularly assessing the integrity of the chassis and the shielding of the cables prevents accumulation of static potential, which could otherwise interfere with the sensitive pressure transducers used in plethysmography or spirometry. By systematically auditing these systems for structural faults, you isolate the hardware from potential failure points long before they manifest during an active procedure. Managing gas supplies and pressure relief variables requires strict adherence to institutional and legal safety guidelines. Every pulmonary lab relies on a manifold system to deliver calibration gases, and these tanks must be secured upright at all times to prevent valve damage or accidental projectile displacement. Pressure relief valves serve as critical mechanical safeguards within these gas delivery circuits, acting to vent excess pressure should the regulation system fail or an obstruction occur downstream. When dealing with environmental variables, specifically in scenarios that approach hyperbaric or hypobaric conditions, the mechanical stress on the hardware increases exponentially. You need to ensure that the equipment is rated and certified for the specific atmospheric pressures it will encounter. Otherwise, the internal sensors may drift, or the hardware enclosures might suffer structural fatigue. Establishing clear protocols for hardware emergency isolation allows you to instantly terminate gas flow or power if a sudden pressure spike or electrical excursion occurs. Beyond electrical and mechanical stability, we must address the persistent threat of cross-contamination during diagnostic testing. While many systems utilize disposable mouthpieces, the internal circuitry of a bellows or turbine-based spirometer can harbor particulate matter and microorganisms if left unprotected. The standard of care mandates the use of specialized inline barrier filters, which are engineered to intercept the moisture, droplets, and biological debris inherent in an exhaled breath. It is important to remember that these filters create resistance, so you must select ones that meet the established resistance threshold for your specific diagnostic device to ensure the flow volume loop remains accurate. By creating this physical barrier, you maintain a clean diagnostic path and protect the long-term integrity of the hardware sensors. Furthermore, maintaining these configurations within legal diagnostic laboratory limits ensures that your lab remains compliant during any external quality auditing or safety inspections. See you in the next lecture. Welcome back to our study of laboratory quality control, where we will now master the rigorous calibration protocols required to ensure the accuracy of pulmonary function testing equipment. Calibration is not merely a formality, it is the bedrock of clinical reliability in the pulmonary function laboratory. When we speak of daily volume calibration using a 3-liter syringe, we are verifying the mechanical integrity of the spirometer's volume transducer. The ATS/ERS guidelines explicitly demand that we inject the 3-liter volume at varying speeds, typically ranging from 0.5 to 12 liters per second, to assess the linearity of the device across the entire physiological spectrum. If a device fails to accurately measure the volume at low or high flows, it suggests a mechanical obstruction or a calibration drift that must be rectified before patient testing proceeds. You must document every injection, confirming that the measured volume remains within the acceptable tolerance, usually within 3% of the expected 3 liters. Failure to maintain these tolerances compromises the validity of every FVC and FEV1 measurement collected throughout the day. Gas analyzer calibration requires an equally disciplined 2-point approach, usually utilizing a known concentration of certified medical gas. We perform a 0-point calibration using ambient air if appropriate, or a secondary gas that does not contain the analyte, followed by a span point calibration using a gas of known concentration near the expected physiological range. This process accounts for sensor degradation and potential electronic drift, which are inevitable in delicate electrochemical or infrared sensors. When calibrating diffusion capacity systems, for instance, the accuracy of the gas analyzer is paramount, as even minor deviations in the reported concentration lead to significant errors in the calculated DLCO. Always ensure your gas mixtures are within their expiration dates, as compromised tanks provide unreliable benchmarks that invalidate the entire calibration process. Body plethysmography introduces a unique set of challenges because the entire system architecture, including the box itself, must be verified for accuracy and stability. To calibrate the plethysmograph, we utilize physical sinus wave simulators that provide a known volume change within the box, simulating thoracic gas compression and expansion. Alternatively, some systems employ internal electronic leaks or pressure-generating devices to confirm that the transducer sensitivity reflects physical reality. We are essentially verifying the box's ability to calculate the thoracic gas volume by measuring the pressure-volume relationship during simulated efforts. If your volume measurements drift during these simulations, check for leaks in the door seals or patient circuit connections, as even a microscopic loss of pressure integrity will skew your plethysmographic results. Managing external variables, such as barometric pressure and ambient temperature, is essential for maintaining the stability of your equipment. Most modern software compensates for these fluctuations automatically, but you must ensure that your laboratory environment remains within the specified range for accurate BTPS correction. If the ambient temperature varies significantly throughout the shift, your calibration records must reflect these shifts as gas density changes with temperature. Furthermore, documenting every maintenance event and calibration check is not just a best practice. It is a clinical and legal requirement for laboratory accreditation. You should maintain a clean, organized, and chronologically ordered log that demonstrates a continuous adherence to the established quality control protocols. When we encounter calibration errors, we move beyond simple adjustment and into the realm of quantitative analysis. Calculating the error percentage is a straightforward yet critical step involving the subtraction of the measured value from the expected value, divided by the expected value, and then multiplied by 100. If this percentage exceeds the tolerance limit, you must adjust the hardware gain settings or potentially replace failing components if the drift persists. Never attempt to force a passing calibration by ignoring repeated failures. Such choices introduce systemic bias into patient data that, in a clinical setting, could lead to incorrect diagnostic conclusions. By rigorously following these sequences, you protect the patient and ensure that the laboratory remains an accurate diagnostic resource. I look forward to our next session together. Welcome back. In this lesson, we will focus on the fundamental methodology for establishing and maintaining a robust biological control program within your pulmonary function laboratory. While mechanical calibration using a 3-liter syringe is a mandatory requirement for quality assurance, it often fails to detect subtle, long-term drifts in equipment sensors that can impact longitudinal data. Biological controls fill this void by utilizing a consistent, healthy individual, often a laboratory staff member, to perform standardized maneuvers at regular intervals. The primary objective here is not to calibrate the machine, but to track the performance of the system over time compared to a known, stable baseline. By observing the same person repeatedly, you isolate the variance of the equipment from the variables inherent in a diverse patient population. This creates an internal gold standard that provides an early warning system before a piece of equipment drifts outside of acceptable clinical limits. You must ensure that these tests are performed under the same conditions, using the same technique, and preferably by the same operators to reduce noise in your dataset. To establish a baseline for your biological control subject, you must collect a series of at least 10 to 20 maneuvers performed over a period of several weeks in a rested and healthy state. Once you have this initial dataset, you calculate the mean and the standard deviation for key parameters such as FVC and FEV1 to define the target range for your ongoing quality control. A common practice is to establish a threshold based on the coefficient of variation, which represents the ratio of the standard deviation to the mean. If a daily biological control test falls outside of 2 standard deviations from your established mean, it serves as a red flag that requires immediate investigation. This does not necessarily mean the machine is broken, but it does mean it is no longer operating within the parameters that produced your established, consistent baseline. Because human subjects can have transient physiological shifts due to fatigue, minor illnesses, or changes in training, you must be disciplined in your documentation. Differentiating between a transient biological fluctuation and genuine equipment drift requires careful longitudinal tracking of the control data. For instance, if you notice a gradual downward trend in FEV1 across several weeks of testing, this is almost certainly an indication of physical sensor degradation or baseline drift rather than a sudden illness in the test subject. In such cases, you should perform a thorough mechanical calibration and potentially check for internal leaks or filter obstructions before continuing diagnostic procedures on patients. If the biological control results return to the mean after a preventative maintenance procedure or a sensor recalibration, you have successfully confirmed the source of the variance. Conversely, if the machine passes all mechanical calibrations but the biological subject consistently produces lower than mean results, you must examine the testing environment or the subject's technique. This rigorous interaction between mechanical data and biological results is what sustains high-quality diagnostic standards in any professional pulmonary function facility. Maintaining these records over long periods allows for a more nuanced understanding of your system's total error, encompassing both the measurement chain and the environmental variables. When a biological subject reaches a point where they are no longer available or their pulmonary function changes due to age or health, transitioning to a new subject requires an overlap period. During this transition, you should have the new subject perform alongside the existing one to correlate their baselines, ensuring that your quality control data does not suffer a sudden discontinuity. Establishing a written protocol for these exit and entry procedures is essential for regulatory compliance and continuity of care. By staying vigilant with your biological control program, you transform your laboratory from a reactive environment into one that proactively manages precision and accuracy. This investment in data consistency is what separates an average lab from an exceptional one, ultimately providing the most reliable diagnostic data for your patients. I look forward to our next session. Welcome back. In this lesson, we will focus on interpreting quality control data, which is essential to ensure the reliability and clinical validity of your pulmonary function testing results. Reliable data requires a disciplined application of statistical quality control, which moves beyond simple visual inspections of charts. When we talk about Levy-Jennings charts, we are essentially looking at a graphical representation of the mean and standard deviation of our control values over time. Ideally, the data points should oscillate randomly around the central mean, reflecting the inherent variability of any measurement system. If you see a point that falls outside the two standard deviation boundary, you must treat it as a warning, though it does not necessarily demand immediate cessation of testing. However, when a point crosses the three standard deviation limit, you are effectively staring at a failure that requires an immediate investigation into the measurement chain. The power of these charts lies in their ability to provide a historical perspective, allowing you to catch errors before they become clinically significant. To bring rigor to this analysis, we employ Westgard rules, which act as a set of logical gates for our quality control process. You can think of these as a series of if-then-else conditions applied to your data points to decide if a process is in control or not. For example, a 1 to 3s rule is triggered when a single control measurement exceeds the mean by more than 3 standard deviations, signaling a random error of significant magnitude. Conversely, rules like 2-2s or 4-1s are designed to detect systematic shifts that indicate a bias in your sensor calibration or gas source integrity. By applying these rules systematically, you avoid the subjective interpretation that often leads to inconsistent laboratory performance. This methodology forces you to categorize deviations correctly, separating simple background noise from genuine technical deterioration. When analyzing these plots, you must distinguish between a random error and a systematic shift. A random error is statistically unpredictable and often appears as an isolated, erratic spike in your data, which might be caused by a temporary electrical interference or a momentary handling error. A systematic shift is far more insidious because it represents a persistent change in the mean value of your measurements, pointing toward a degradation in sensor hardware or a change in the composition of your calibration gases. If you observe a steady, slow change over several days, this is likely a trend related to sensor aging or a drift in the electronics. Addressing these issues early requires that you not only identify the mathematical flag, but also perform a root cause analysis to determine if the equipment requires a full calibration or a component replacement. Baseline stability is another critical dimension of your quality control strategy, particularly when dealing with gas analyzers and sensors. If you notice a gradual shift in the baseline that persists across multiple patient tests, you are likely looking at gas contamination or a failure in the scrubbing system that removes CO2 or water vapor. Whenever these deviations occur, you must pause operations and verify the integrity of the ambient air reference samples before attempting any further diagnostic procedures. It is a fundamental responsibility to ensure that the patient's clinical data is not conflated with technical noise. If the quality control status remains suspect, you must establish clear, predetermined protocols for stopping the diagnostic run, informing the attending physician, and documenting the failure before conducting any corrective maintenance or recalibration activities. See you in the next lecture. Welcome back. In this session, we will examine the systematic approach to preventative maintenance procedures required to maintain laboratory standards and ensure equipment longevity. Maintaining a pulmonary function laboratory requires a disciplined approach to the life cycle of every component within your system. You cannot simply wait for a device to fail before you consider its health, because the data we provide to clinicians is only as reliable as the hardware that produces it. Your primary goal is to establish a rigorous, time-based schedule for routine care that minimizes downtime while maximizing accuracy. This begins with the pneumotachometer, which is often the most sensitive part of a spirometry system. When cleaning these screens, you must exercise extreme caution to avoid warping the delicate mesh or heating elements. Any physical deformation of the screen changes its resistance characteristics, which directly impacts the flow-pressure relationship and invalidates your calibration constants. Always use the manufacturer-recommended cleaning agents and drying methods, ensuring that you never apply mechanical stress that could shift the calibration baseline during the maintenance routine. Moving beyond flow sensors, your routine must also encompass the chemical and optical gas analyzers essential for accurate diffusing capacity and lung volume measurements. These sensors have finite lifespans dictated by their exposure to oxygen, moisture, and CO2, necessitating proactive replacement cycles. For example, oxygen sensors are typically electrochemical cells that degrade regardless of usage intensity, meaning you must track their installation date rather than just the number of tests performed. Similarly, the desiccant materials used to protect these sensitive analyzers from humidity must be monitored and replaced before they reach their saturation point. If the desiccant changes color or the system internal humidity levels rise, you are already risking damage to the internal optical benches. Implementing a tracking system for these component version numbers ensures that you aren't caught off guard by a sensor reaching its chemical end of life during a patient test. A often overlooked, yet critical aspect of hardware maintenance is the structural integrity of the body plethysmograph, specifically regarding the shutter mechanism. The shutter seals are subject to constant mechanical wear during every panting maneuver, and small leaks here can introduce significant volume errors that distort the calculation of thoracic gas volume. When these seals begin to show signs of degradation, you must follow the precise instructions to rebuild or replace the assembly without introducing new air leaks. Once any component, be it a seal, a sensor, or a circuit board, is updated or replaced, you must perform a comprehensive validation check. This is not optional. It is a regulatory requirement that proves the system is still operating within the specified error tolerances. Your documentation should clearly state the date of the maintenance, the serial numbers of new parts installed, and the post-maintenance calibration data confirming that the system is ready for clinical use. Compliance is not just about keeping the machine running. It is about proving that it was running correctly at the time of each patient encounter. Regulatory bodies require a verifiable paper trail that tracks component lifespans, software version history, and all maintenance actions performed by technicians. If you replace a sensor but fail to update the system metadata or log the change in your quality assurance records, you have effectively created a gap in your laboratory's compliance history. This documentation must include the specific validation steps taken after an update, such as a multi-point calibration check or a biological control test to verify physiological measurement stability. Maintaining this level of detail requires that you treat your laboratory instrumentation as a precision system, where every recorded data point is supported by an audit trail of maintenance. By adhering to these schedules and technical instructions, you build a foundation of reliability that is beyond reproach to both internal auditors and regulatory inspectors. See you in the next lecture. Welcome back. In this lesson, we will focus on the systematic approach required to troubleshoot and resolve common instrumentation failures encountered in a pulmonary function laboratory. When a system fails under the pressure of a clinical environment, our primary goal is to isolate the fault without compromising patient safety or data integrity. You should always start by applying a diagnostic algorithm that separates hardware anomalies from software errors and calibration drift. For instance, if you encounter a plethysmographic cabinet that refuses to seal or loses pressure, your first step is a logical inspection of the door gaskets and the integrity of the pressure transducer tubing. A simple leak can mimic significant physiological changes, so systematically check the pneumatic pathways for blockages or micro tears in the flexible connections. If the cabinet pressure remains unstable despite these checks, the issue likely stems from a faulty internal relief valve rather than a user error. By ruling out simple mechanical failures first, you minimize downtime and prevent unnecessary service calls that could have been resolved at the workstation level. In the domain of electrochemical cells, detecting constant baseline drift is a routine but critical task that often points to sensor exhaustion or unstable environmental variables. If your oxygen or carbon dioxide sensors exhibit a slowly wandering baseline that refuses to stabilize after a standard calibration, you must first verify the chemical life of the electrolyte or the membrane status. Consistent drift suggests that the sensor is no longer capable of reaching equilibrium, which is frequently caused by ambient temperature fluctuations or interference from electromagnetic sources near the circuit board. Always cross-reference the manufacturer's specifications for the expected signal voltage to determine if the drift is within tolerance or if a complete replacement is required. Keeping a detailed log of these drift patterns can also help you predict sensor failure before it happens during a diagnostic session, allowing for proactive maintenance rather than reactive troubleshooting. Communication dropouts between the external sensors and your diagnostic workstation often manifest as jittery, incomplete, or frozen digital signals. When this happens, verify the physical circuit continuity of the signal cables before assuming a software crash or an interface module failure. Moisture condensation is another subtle but common offender, especially in flow sensing equipment, where small droplets can distort the laminar flow and create irregular, erratic readings on your display. If you detect unexplained spikes or valleys in your flow volume loops, check for condensation inside the pneumaticograph and clear the lines according to your laboratory's sterile technique protocols. Should the issue persist after ensuring the pathway is dry and the cables are secure, analyze the system error logs to pinpoint if the communication handshake is failing at the port level. Sampling pump failures can bring your diffusing capacity or gas analysis testing to an immediate halt, but they are often solvable through careful observation of flow pressures. If the pump is running but failing to draw a consistent sample, look for occlusions in the intake manifold or a fatigue-induced failure in the internal pump diaphragm. While you might be tempted to implement temporary hardware overrides to finish a current patient, you must always evaluate if such a decision compromises the accuracy of the result. If a bypass or a pressure setting adjustment does not yield a stable, repeatable signal against a known calibration source, you must remove the device from active service immediately. Systematic fault isolation is not just about keeping the machine running. It is about recognizing when the technical limitations demand a professional service intervention to maintain clinical precision. I will see you in the next lecture. Welcome back. In this lesson, we will examine the regulatory frameworks that govern the daily operations of a pulmonary function laboratory and how you can maintain compliance to meet institutional standards. To operate a pulmonary function lab, one must navigate a complex web of oversight from bodies like CLIA, OSHA, the ATS, the ERS, and the Joint Commission. CLIA, the Clinical Laboratory Improvement Amendments, dictates the standards for laboratory testing to ensure accuracy, reliability, and timeliness of patient exam results. While many PFT labs fall under moderate complexity testing, it is vital to understand that licensure is not merely a box-ticking exercise. It is a foundational requirement for patient safety. Simultaneously, OSHA mandates strict chemical safety protocols, specifically regarding the handling of hazardous materials. This includes maintaining clear, updated safety data sheets for every gas, cleaning agent, and calibration solution in your department. Neglecting these documentation paths exposes the organization to significant legal risk and can result in the loss of laboratory accreditation during unannounced site visits. Organization of your calibration binders represents more than just clerical work. It serves as your primary evidence of ongoing instrument performance. You must track every daily and monthly calibration verification, ensuring that each report links back to a traceable reference gas standard. These gases must be certified for accuracy, and their cylinders must be stored according to strict National Fire Protection Association protocols, which typically include securing them upright, grouping by content, and separating full from empty supplies. Furthermore, the Joint Commission emphasizes the importance of Technologist competency metrics. You need a formalized process that audits how specific individuals conduct maneuvers, measuring their adherence to ATS and ERS standards, and verifying that their training is current. This is not just about having a paper trail, but about fostering a culture where every technician understands why these markers matter for the integrity of the diagnostic data. Data privacy constitutes another core pillar of your compliance framework, particularly as it relates to the digital storage of patient pulmonary records. Under current healthcare privacy regulations, you are legally and ethically obligated to ensure that PFT data is protected during transmission and at rest within your electronic reporting systems. Any audit of your laboratory will likely look for evidence of how you manage access controls and how you prevent unauthorized viewing of protected health information. This level of diligence extends to quality improvement, where you must demonstrate that you are actively responding to detected errors rather than ignoring trends in machine failure or technician drift. A robust laboratory operation uses incident reports as a mechanism for change, creating a closed-loop system where data quality issues are identified and systematically resolved. When you arrive for an inspection, Your ability to produce consistent, compliant, and well-organized records will be the defining factor in your laboratory success. See you in the next lecture. Welcome to our detailed exploration of spirometry execution and maneuvers, where we will refine the essential clinical skills required for precise diagnostic outcomes. This chapter is designed to transition you from theoretical knowledge to high-level technical proficiency in managing pulmonary function diagnostics. Achieving high-quality spirometry data depends entirely on the technologist's ability to guide the patient through a series of specific, high-effort respiratory maneuvers. The process begins with proper posture, which requires the patient to sit upright with their feet flat on the floor and their chin slightly elevated to ensure an open airway. It is imperative that you maintain a neutral and authoritative tone when giving instructions, as panic or poor communication can lead to suboptimal efforts. You must prepare the patient to take the largest possible inspiration to total lung capacity, followed immediately by a rapid, hard, and complete blast of exhalation. Instructing the patient to achieve a sharp start is vital for accurate back extrapolation measurements, as a slow start will artificially reduce the measured forced expiratory volume in 1 second. Consistency in your coaching wording, such as urging the patient to keep blowing until the lungs are empty, ensures that the patient does not terminate the maneuver prematurely. Recognizing unacceptable maneuvers is often what separates an expert technologist from a novice during the examination process. A primary concern is glottic closure, which manifests as an abrupt cessation of flow despite the patient's continued physical effort. You should also watch carefully for leaks around the mouthpiece or tongue placement, as these cause distinct, sharp drops in flow volume readings. If a patient coughs during the first second of expiration, the data becomes unusable for volume time metrics and must be flagged immediately. Early termination, defined as ending the maneuver before reaching the required duration or prior to reaching a plateau, will consistently yield an inaccurate forced vital capacity measurement. By maintaining your focus on the real-time flow volume loop, you can immediately identify these failures and provide constructive feedback to the patient before proceeding with subsequent attempts. The American Thoracic Society outlines strict reproducibility criteria that every technologist must strictly follow to ensure the integrity of the dataset. Specifically, you are aiming to obtain at least 3 acceptable maneuvers where the largest forced vital capacity and the largest forced expiratory volume in 1 second are within 0.150 liters of each other. If the patient fails to meet these criteria, you may need to perform up to 8 maneuvers, provided the patient is not experiencing fatigue or distress. As a technologist, your role involves evaluating these metrics after every single effort, allowing you to push for better reproducibility without inducing exhaustion in the patient. If you notice a decline in performance after several attempts, it is your professional responsibility to recognize the onset of respiratory muscle fatigue and determine if the procedure needs to be paused or stopped entirely. Beyond basic forced vital capacity maneuvers, you must also be capable of coaching for the peak expiratory flow and maximal voluntary ventilation. Peak flow requires an explosive, near instantaneous effort from the very start of the maneuver, which can be difficult for patients who struggle with the biomechanics of a forced blast. The maximal voluntary ventilation maneuver is uniquely demanding, requiring the patient to breathe as rapidly and deeply as possible for a sustained 10 to 12 seconds. This specific test is rarely about the volume of breath, but rather about the patient's ability to maintain a high level of minute ventilation without becoming lightheaded or hyperventilating. Always keep a close eye on the patient for signs of syncope or dizziness during these more taxing maneuvers, as safety must always take precedence over the acquisition of data. Effectively, managing the patient interface requires you to adjust your coaching style to fit the personality and cognitive state of the individual in front of you. Some patients respond better to simple, direct commands like blast it out, while others may require more empathetic guidance to overcome anxiety. Your ability to translate these complex physiological requirements into simple, actionable steps is what defines high-quality care in the pulmonary function laboratory. Always perform a quick check for back extrapolation to ensure that common errors in maneuver initiation are not undermining the validity of your results. If the back extrapolated volume exceeds 5% of the forced vital capacity or 0.150 liters, the maneuver is technically invalid, and you must coach the patient to start the next effort with more immediacy. By systematically applying these standards, you protect the clinical validity of the exam and ensure that the patient's pulmonary function status is accurately represented in the diagnostic record. I will see you in the next lecture. Welcome back. In this chapter, we explore the nuances of flow volume loop analysis, specifically focusing on how graphical morphology serves as a diagnostic window into pulmonary health. To master flow volume loop analysis, you must begin by viewing the graph not merely as a collection of lines, but as a precise representation of mechanical lung function. The expiratory limb is characterized by an initial rapid rise to peak expiratory flow, which is heavily dependent on patient effort, followed by a linear or curvilinear descent that represents the effort-independent portion of the maneuver. This latter segment is dictated by the elastic recoil of the lungs and the resistance of the airways, making it the most clinically significant section for identifying early disease. When we analyze the shape of this effort-independent portion, specifically looking at the flow rates at 50% and 75% of expired volume, we can detect minute changes in peripheral airway obstruction. A concave or scooped appearance in this segment indicates air trapping, often seen in obstructive conditions like asthma or chronic obstructive pulmonary disease, because the narrowed airways collapse prematurely under the pressure exerted during forced expiration. Moving beyond simple obstruction, the morphology of the loop provides critical insights into upper airway dynamics through patterns of flow limitation. A fixed upper airway obstruction is characterized by a significant flattening of both the inspiratory and expiratory loops, resulting in a squared-off or plateaued configuration that ignores the usual effort-dependent peak. This happens because the airway diameter remains constant regardless of the pressure changes occurring during the respiratory cycle, effectively capping the flow rate at both ends. Conversely, variable extrathoracic obstructions exhibit flattening only during the inspiratory phase, as the negative pressure generated during inhalation draws the collapsible tissue into the airway lumen. Variable intrathoracic obstructions behave differently, showing flow limitations specifically during the expiratory phase when positive pleural pressure compresses the airway, preventing the standard peak flow trajectory typically observed in healthy individuals. Beyond these structural obstructions, the precise deconstruction of the loop requires an eye for specific artifacts and secondary markers that can signify underlying neurological or systemic issues. Micro-oscillations along the expiratory limb often point toward voluntary or involuntary tremor-like activity within the respiratory musculature, frequently manifesting in patients with neuromuscular disease. While interpreting these features, you must carefully distinguish between genuine pathological patterns and suboptimal patient performance, such as an incomplete maneuver or lack of sustained effort. A poor patient effort usually presents as a truncation of the loop, meaning the patient terminated the maneuver prematurely, leading to a missing volume or an incorrectly positioned peak flow. To validate the data, always inspect for a smooth transition from inspiration to expiration, and ensure that the loop closes properly at the volume axis, signifying an accurate measurement of the total forced vital capacity. By synthesizing these visual markers, the initial peak flow, the slope of the effort-independent phase, and the presence or absence of plateaus, you gain the ability to differentiate complex physiological states that numerical data alone might obscure. Remember that the NBRC exam often tests your ability to translate these shapes directly into diagnostic conclusions, particularly when multiple patterns overlap in a single patient. Relying on your ability to visualize the mechanics behind the curve will ensure you correctly identify constraints which are otherwise easily missed. You have now established a foundational framework for interpreting these critical diagnostic profiles systematically. I look forward to seeing you in the next session. Welcome to our lecture on lung volume measurement techniques. In this session, we will examine the comparative protocols and technical nuances required for precise lung volume assessment. When we approach the measurement of static lung volumes, we are essentially trying to quantify the gas remaining in the lungs after a tidal breath, specifically the functional residual capacity. While simple spirometry provides a reliable baseline for flow-based variables, it lacks the ability to measure the volume of gas that does not move during quiet breathing. To capture this, we employ three primary modalities: body plethysmography, open-circuit nitrogen washout, and closed-circuit helium dilution. Each method relies on different physical principles, and understanding their individual operational mechanisms allows a technologist to identify why a patient might show discordant results between tests. Plethysmography utilizes Boyle's law, relating pressure and volume changes within an isothermal environment to determine thoracic gas volume. In contrast, gas dilution techniques rely on the conservation of mass, using an inert tracer gas to equilibrate with the lung's internal volume. Choosing the correct tool requires not only technical proficiency, but also an understanding of the patient's specific pulmonary architecture. Body plethysmography is often considered the gold standard in clinical settings due to its speed and ability to measure total thoracic gas. During this procedure, the patient sits inside a clear, airtight chamber while the shutter closes at the end of a normal expiration. The patient then performs gentle panting maneuvers against the closed shutter, which creates fluctuations in pressure that we use to calculate the volume. A primary technical concern here is ensuring the shutter closure occurs precisely at the functional residual capacity, as premature or late closure leads to inaccurate measurements of the starting volume. Furthermore, if a patient has severe emphysema, the trapped, poorly communicating gas within hyperinflated alveoli will be included in this measurement. This often results in a significantly higher total lung capacity compared to gas dilution methods, which only measure communicating gas. A technologist must be vigilant in identifying these discrepancies, as they hold significant diagnostic value for obstructive disease staging. Open-circuit nitrogen washout presents an entirely different set of technical challenges that demand constant focus from the operator. The patient breathes 100% oxygen, washing out the nitrogen originally present in their functional residual capacity into a collection system. We continue this process until the nitrogen concentration drops to less than 1%, signaling that equilibration is complete. The total volume of nitrogen cleared, divided by the starting concentration, provides the volume of the lungs at the start of the test. Problems frequently arise if there's a leak in the patient's circuit or if the nose clip is inadequately placed, causing room air to contaminate the sample. Because we are tracking the clearance curve, any ambient air intrusion will artificially prolong the test or yield an erroneous volume estimation. Precision here is defined by our ability to monitor the final nitrogen concentration slope until the predetermined endpoint is met. Helium dilution is a closed-circuit method that utilizes the principle of gas concentration equilibrium to determine lung volume. We put a known concentration of helium into a rebreathing circuit, and as the patient breathes, the helium becomes diluted by the air already inside the lungs. We must carefully manage the oxygen addition lines during the equilibration phase to keep the system volume constant and compensate for the oxygen consumed by the patient. If the oxygen addition is not balanced correctly, the system volume drifts, rendering the final calculation unreliable. This method requires the patient to breathe until the helium concentration remains stable for a set period, indicating that the tracer gas has reached all communicating lung units. Much like the nitrogen washout, this method fails to account for air that is poorly ventilated, which is why we compare these results directly against plethysmography in patients with air trapping. Finally, we must address the compounding errors that can invalidate our findings across all these modalities, starting with dead space. Any equipment that adds dead space to the breathing circuit will modify the effective ventilation and, if not precisely corrected in our software, will lead to an overestimation of the functional residual capacity. We also see technical errors stemming from patient movement, poor mask seal, or improper temperature stabilization of the gas sensors. As technologists, our role is to act as the primary filter for the quality of this physiologic data. If the patient is struggling with the maneuvers, or if the internal sensors indicate a failure to reach steady state, we must intervene before the data is finalized. Mastery of these techniques requires you to understand not just how to run the software, but how the underlying physics dictates the reliability of every reading you produce. See you in the next lecture. Welcome back. Today we are moving into the diffusing capacity testing methodology chapter, where we will examine the standard single-breath carbon monoxide technique in depth. We will cover the technical execution, gas analysis, and critical adjustments necessary for accurate clinical results. The single-breath carbon monoxide diffusing capacity, or DLCO maneuver, is arguably the most sensitive test in the pulmonary laboratory for assessing the integrity of the alveolar capillary membrane. To perform this correctly, you must ensure the patient starts from a position of full exhalation to residual volume before initiating a rapid, deep inspiration. The inspiratory volume must reach at least 90% of the patient's measured vital capacity to ensure adequate lung expansion and alveolar recruitment. This standardization is mandatory because the DLCO result is highly dependent on the total volume of gas involved in the exchange process. If the patient fails to reach these volume thresholds, the resulting calculation will be artificially depressed, leading to a false indication of impaired diffusion. You are essentially measuring the ability of gas to traverse from the alveoli into the hemoglobin-laden erythrocytes within the pulmonary capillaries. Once the patient has fully inspired the test gas mixture, the breath hold phase begins, typically lasting 10 seconds. The test gas contains a small, non-reactive tracer gas, usually helium or methane, used to determine the alveolar volume, and a small concentration of carbon monoxide as the test gas. When measuring the breath hold timing, we generally apply the Jones-Meade method, which calculates the start of the breath hold at the midpoint of inspiration and the end at the midpoint of the actual sample collection. This timing configuration accounts for the time during which gas exchange is actively occurring throughout the maneuver. Proper isolation of these intervals is critical because any error in timing duration will directly introduce mathematical bias into your final diffusing capacity report. Consistency in these time-based intervals ensures that your results remain reproducible across different sessions and equipment platforms. The anatomical dead space must be cleared during the initiation of the exhalation phase so that the sample represents true alveolar gas. We accomplish this by utilizing a specific sample collection window, where the first portion of the exhaled gas, which reflects the volume of the conducting airways, is discarded. By isolating the second portion of the exhaled air, we capture gas that has been in contact with the alveolar surface where actual diffusion takes place. If your mechanical dead space or anatomical clearance window is set incorrectly, you risk diluting the sample with inspired air or poorly equilibrated gas. Consequently, the helium dilution and carbon monoxide uptake values would appear erroneous, ruining the validity of the entire test attempt. Always verify the volume of the sample bag or the automated sensor window against the laboratory's standard operating procedures for the specific equipment in use. Finally, we must address the essential corrections applied to the raw data output to arrive at an accurate physiological assessment. The initial hemoglobin concentration significantly affects the uptake of carbon monoxide, because hemoglobin is the primary binding site for the gas. Therefore, you must adjust the measured DLCO if the patient is anemic or polycythemic. Furthermore, elevated levels of carboxyhemoglobin, often seen in smokers, will inhibit the transfer of the test gas, requiring a corrective formula at the point of interpretation. Atmospheric pressure and altitude also introduce variances that shift the partial pressure gradients across the alveolar capillary membrane, necessitating a barometric pressure correction. Lastly, the alveolar volume ratio is used to correlate the measured diffusing capacity with the actual lung volume achieved, providing the DLVA ratio, which distinguishes true membrane defects from reduced capacity due to low lung volumes. I will see you in the next lecture. Welcome to our discussion on identifying obstructive and restrictive patterns in pulmonary function testing. We will now focus on the algorithmic application of data to differentiate between air-trapping diseases and interstitial structural limitations. When we approach the interpretation of pulmonary function tests, we must move beyond the reliance on fixed percentage cutoffs. Historically, the use of 80% of predicted values as a universal threshold for normality has introduced significant inaccuracies, particularly in geriatric populations or those with atypical body builds. Instead, we must prioritize the lower limit of normal, which is calculated based on the 5th percentile of a healthy reference population. By employing the lower limit of normal, we align our diagnostic threshold with the statistical variability inherent in human biology, thereby reducing the frequency of false positive diagnoses. This approach requires a thorough understanding of the relationship between forced expiratory volume in 1 second and forced vital capacity, commonly referred to as the FEV1-FVC ratio. When this ratio falls below the threshold, our primary focus shifts toward obstruction, necessitating a detailed look at flow volume loop morphology. To confirm a restrictive pattern, one must reconcile the spirometric findings with absolute lung volume measurements, specifically the total lung capacity. A reduced FVC can imply restriction, but it is frequently an artifact of poor effort or unrecognized airway obstruction. Only when the total lung capacity also falls below the lower limit of normal can we confidently classify the physiological state as restrictive. We must then distinguish between parenchymal processes, such as interstitial lung disease, and extraparenchymal influences like severe obesity or thoracic deformity. In the context of obesity, the expiratory reserve volume is typically diminished, yet the total lung capacity may remain within normal bounds because the lungs are not inherently scarred or fibrotic. Always verify that your plethysmographic volume data is internally consistent before finalizing such an interpretation. Air trapping is defined through another specific numeric relationship, primarily the residual volume to total lung capacity ratio. As intrinsic airway disease progresses, the residual volume increases disproportionately to the total lung capacity, signaling that the patient cannot empty their lungs effectively at the end of a forced expiration. If you observe an elevated residual volume to total lung capacity ratio alongside a preserved functional residual capacity, you are likely witnessing hyperinflation caused by obstructive phenomena. The technologist must integrate these findings into a unified report that reflects the severity of the impairment. Categorizing these patterns requires a systematic evaluation of whether the physiological profile is purely obstructive, purely restrictive, or a mixed manifestation. If both the forced expiratory ratio and the lung volumes are compromised, we are dealing with a complex clinical presentation that requires precise documentation. Effective data synthesis demands that we look at the flow volume loop with a critical eye, even before we consult the numeric printout. An obstructive process typically presents with a concave shape during the expiratory phase, signifying the gradual collapse of airways during high-flow maneuvers. Conversely, a purely restrictive disorder often produces a smaller, narrow loop that retains a relatively normal peaked shape or even a shifted characteristic reflecting increased elastic recoil. We must be cautious not to prematurely categorize a patient based on partial data if the maneuvers were not reproducible according to current laboratory standards. Validation of the maneuver is the most important step in the entire diagnostic cycle because no algorithm can fix a faulty expiration. If the testing data does not exhibit signs of clear effort or consistency, the subsequent classification of obstruction or restriction will be inherently flawed. The clinical significance of identifying these patterns rests on our ability to distinguish between recoverable or manageable air trapping and permanent structural limitations. While chronic obstructive pulmonary disease manifests as a progressive decline in expiratory flow, interstitial conditions show a decrease in compliance that makes lung expansion energy-intensive for the patient. By keeping our methodology consistent and grounded in valid reference strategies, we provide the physician with a reliable roadmap for treatment. Whether you are dealing with a patient presenting with an obstructive FEV1-FVC ratio or a restrictive total lung capacity deficit, your data synthesis remains the cornerstone of the diagnostic process. This structured internal review ensures that our reports are not just collections of numbers, but accurate reflections of the patient's underlying respiratory health. I will see you in the next lesson. Welcome back. In this lesson, we will focus on the nuanced task of validating pulmonary function test results by identifying cross-test inconsistencies and optimizing procedural quality. Achieving high-quality data requires more than simply following standard operating procedures. It demands a critical eye for internal physiological consistency across the entire testing profile. When a patient performs a slow vital capacity, or SVC, it should generally be greater than or equal to their forced vital capacity, or FVC, because the latter is limited by the physical compression of the airways during a rapid expiratory effort. If you observe an FVC that is significantly higher than the SVC, this is a technical red flag indicating either poor patient effort during the slow maneuver or an inadequate inspiration in the forced maneuver. It is your job as a technologist to recognize this discrepancy immediately and facilitate maneuvers that allow for proper comparison. A consistent profile is not just about meeting quantitative standards. It is about ensuring that the clinical picture presented by the numbers makes biological sense. Beyond simple maneuvers, the cross-checking of lung volumes provides an essential layer of verification that distinguishes between physiological reality and measurement artifact. When performing plethysmography, which measures total thoracic gas volume including air trapped behind obstructed airways, it is common to compare these results against gas dilution methods like helium dilution or nitrogen washout. If the plethysmographic volume is significantly larger than the dilution volume, this discrepancy usually points toward gas trapping or bullous disease, where gas communication is poor. However, if there is no underlying pathology to explain this difference, you must investigate the possibility of equipment leaks or thermal instability within the plethysmography box itself. Establishing this internal consistency acts as an anchor for the interpreting physician, giving them the necessary context to determine whether a diagnosis of obstruction is truly supported by the data you have collected. Similar logic applies to the diffusing capacity for carbon monoxide, or DLCO, as its metrics must remain physiologically compatible with the patient's ventilation and volume findings. If a patient presents with a significantly reduced total lung capacity but maintains a normal diffusing capacity corrected for alveolar volume, your assessment should weigh the likelihood of rapid breathing patterns or poor patient coordination during the breath hold maneuver. You must cultivate the habit of documenting these technical caveats clearly, as a physician relying on these values needs to know if a low result is a diagnostic finding or a consequence of a suboptimal testing session. Writing a concise note regarding the patient's ability to follow commands or their physical state during testing can be the difference between a misleading report and a nuanced clinical interpretation. By providing these details, you are effectively closing the loop between the raw data and the patient's actual clinical status. Troubleshooting must be a proactive rather than a reactive process, starting with the ambient environment surrounding the patient. Variations in ambient temperature, barometric pressure, and humidity can significantly skew gas calculations, so verifying that your laboratory environmental sensors are calibrated and stable is non-negotiable. During a session, you should be monitoring the flow volume loop shape for signs of glottic closure or mouth leaks that would suggest the need for immediate coaching. If you notice a premature decline in the expiratory flow, check for a submaximal effort early on rather than waiting until the end of the test to provide feedback. Technical optimization is about managing the human element while maintaining the integrity of the diagnostic equipment, ensuring that what you record is as close to the patient's true physiological capacity as possible. See you in the next lecture. Welcome to our module on blood gas sampling and analysis, where we dive into the technical mastery required for precise diagnostic data collection. In this chapter, we will master the technical nuances of arterial puncture, indwelling line management, and the rigorous processing standards required for accurate blood gas results. Understanding these clinical procedures is fundamental to your success, as the quality of your laboratory data and ultimately the patient's diagnosis depends entirely on the precision of your sampling technique. We begin with the primary sites for arterial access, which are the radial, brachial, and femoral arteries. The radial artery remains the site of choice due to its superficial position and the availability of collateral circulation, which we must always verify before proceeding. Prior to any radial puncture, you must perform a modified Allen test to ensure that the ulnar artery provides adequate perfusion to the hand should the radial vessel be compromised. Failing to confirm this collateral flow is a clinical oversight that can lead to ischemic injury, a complication that remains entirely preventable with proper procedural sequence. The actual collection process requires a meticulous balance of equipment selection and environmental control. For routine punctures, a 22 to 25 gauge needle is typically sufficient, though the diameter should be matched to the vessel size and the urgency of the draw. You must ensure the syringe is properly heparinized, as excessive concentrations of liquid heparin can induce a dilutional error that artificially lowers the partial pressure of carbon dioxide and biases the pH reading. Once the sample is obtained, any air bubbles must be immediately expelled, as they represent a gas reservoir that will rapidly exchange with the blood and invalidate your results through oxygen titration and carbon dioxide washout. Beyond the technical execution of the puncture, you must manage the patient's physiological state during the procedure to ensure the sample reflects their true metabolic status. If a patient becomes anxious or hyperventilates during the draw, the resulting hypocapnia will lead to a falsely elevated pH, masking the patient's true acid-base equilibrium. If you encounter significant patient distress, it is often prudent to pause and allow the patient to return to a steady state before finalizing the collection. This is especially true when dealing with patients who have chronic respiratory conditions, as their baseline values can be easily misinterpreted if the sample is taken during an episode of acute panic. Temperature correction remains a vital component of advanced blood gas analysis, particularly when working with patients exhibiting extreme thermal states. Samples drawn from patients experiencing severe hypothermia or hyperthermia must be corrected for body temperature, as the dissociation curves for both oxygen and carbon dioxide are highly sensitive to thermal shifts. If a sample is processed at standard laboratory temperatures without proper indexing for a hypothermic patient, you will significantly underestimate the actual oxygen tension present in the arterial blood. Consequently, keeping accurate records of the patient's current core temperature is not mere paperwork. It is a clinical requirement for reliable interpretation. Post-collection processing and logistics define the reliability of your data chain. Samples should be analyzed as soon as possible after collection, preferably within 10 to 15 minutes, to minimize the effects of metabolic activity from white blood cells and platelets consuming oxygen. If immediate analysis is impossible, the sample must be stored in an ice bath to depress this cellular metabolism, although this brings its own risks of temporal errors if the storage duration exceeds manufacturer guidelines. Finally, always document the time of draw and any deviations from protocol, as this transparency allows for the intelligent interpretation of the final report by the clinical team. See you in the next lecture. Welcome to our exploration of cardiopulmonary exercise testing protocols, where we will examine the standards for maximal incremental exercise assessment. This chapter provides the technical foundation necessary to master treadmill and cycle ergometer testing using state-of-the-art metabolic carts. Successfully executing maximal incremental exercise tests requires a disciplined approach to equipment preparation and physiological monitoring. Before a patient even steps onto the treadmill or cycle ergometer, we must ensure the metabolic cart is accurate through a rigorous calibration sequence. Oxygen and carbon dioxide sensors require precise calibration against known gas concentrations to ensure the breath-by-breath data reflects the patient's true metabolic state. Simultaneously, the volume turbine or pneumodactygraph must undergo a multi-flow calibration to account for the resistance characteristics of the breathing circuit. Neglecting these calibration steps introduces drift into the respiratory quotient calculations, which renders the resulting ventilatory data unreliable for clinical diagnosis. High-quality data begins with the meticulous maintenance of these sensors, as precise volume and gas concentration measurements are the cornerstones of valid testing. Selecting the appropriate ramp protocol is a strategic decision that balances patient tolerance with the need to reach a true maximal effort within a reasonable time frame. A ramp protocol increases workload in small, continuous increments rather than the larger, discrete stages found in traditional step protocols. For the average healthy individual, a work rate increment that leads to a peak exercise duration of approximately 8 to 12 minutes is ideal. If the increment is too steep, the patient will reach exhaustion prematurely due to muscle fatigue rather than cardiovascular limitation. Conversely, an increment that is too shallow prolongs the procedure unnecessarily, increasing the likelihood of early termination due to boredom or lack of patient motivation. Always consider the patient's baseline fitness level and known pathologies when choosing the ramp slope to obtain the most representative aerobic capacity measurement. Electrocardiogram placement and hemodynamic monitoring provide the safety net that allows us to push patients toward their physiological limits. A 12-lead electrocardiogram must be applied using high-quality adhesive electrodes, meticulously prepped to ensure low impedance despite the inevitability of sweat. Proper lead placement, following the standard Mason-Likar configuration, minimizes movement artifact that can obscure the ST segment during high-intensity exertion. Alongside the heart tracing, continuous blood pressure monitoring is essential to track the workload's effect on the systemic vascular system. A normal response should show a steady rise in systolic pressure with stable or slightly decreasing diastolic pressure, reflecting improved peripheral perfusion. Should systolic pressure plummet or fail to rise with increasing workload, this serves as an immediate warning of potential myocardial ischemia or impaired cardiac output. The anaerobic threshold, or the point at which metabolic demands exceed the capacity of oxidative phosphorylation, requires careful identification using the V-slope or ventilatory equivalent methods. During the test, look for the moment where carbon dioxide production begins to rise disproportionately relative to oxygen consumption, signaling the shift toward anaerobic metabolism. The V-slope method plots carbon dioxide volume against oxygen volume, where the departure from a linear relationship identifies the anaerobic threshold. Alternatively, the ventilatory equivalent method looks for a systematic increase in the ventilatory equivalent for oxygen without a concurrent increase in the ventilatory equivalent for carbon dioxide. Calculating the oxygen pulse, the ratio of oxygen consumption to heart rate, further offers insight into the efficiency of oxygen extraction at the level of the peripheral tissues. Breathing reserve and the respiratory exchange ratio allow us to assess the degree of ventilatory limitation and the metabolic state of the patient. The breathing reserve is calculated by subtracting the peak minute ventilation from the maximum voluntary ventilation, providing an estimate of how much room the patient had to increase ventilation further. A low breathing reserve suggests a primary ventilatory limitation, often associated with restrictive or obstructive lung diseases. Meanwhile, the respiratory exchange ratio, defined as the ratio of carbon dioxide produced to oxygen consumed, serves as an indicator of effort and acid-base balance. During maximal effort, this ratio should ideally exceed 1.1, indicating that the patient has reached a state of significant metabolic stress. As the exercise intensifies and the patient approaches physical failure, recognizing these markers is crucial for validating the true maximum effort of the subject. Absolute termination indications are non-negotiable safety checkpoints that every technologist must commit to memory to prevent adverse events. Should the electrocardiogram reveal significant ST segment depressions or the sudden onset of life-threatening arrhythmias, the test must be discontinued immediately. Other clinical red flags include syncope, severe dizziness, or a documented drop in systolic blood pressure despite an increase in the exercise workload. In these instances, the priority shifts instantly from data collection to patient stabilization and reporting. By maintaining constant situational awareness and keeping a watchful eye on both the metabolic trends and the patient's physical appearance, you effectively protect the subject while ensuring the data collected is both safe and scientifically valid. I will see you in the next lecture. Welcome to the chapter on bronchial provocation challenge testing, where we will examine the precise clinical methodologies used to objectively assess airway hyperresponsiveness. By mastering these protocols, you will gain the diagnostic rigor necessary to effectively differentiate between clinical asthma phenotypes and other restrictive or obstructive pathologies in your patients. Bronchial provocation testing is a clinical diagnostic procedure designed to unmask airway hyperresponsiveness in patients who present with respiratory symptoms but maintain normal or near-normal baseline spirometry. The methacholine challenge remains the gold standard for this assessment, requiring a systematic approach to aerosol delivery to ensure standardized results. Before the patient even arrives at the lab, we must enforce strict medication withholding periods, which typically include abstaining from short-acting beta agonists for at least 8 hours and long-acting beta agonists for up to 48 hours. We also advise the patient to avoid caffeine and smoking on the day of the test to prevent false negative findings. Once the patient is present, we begin by performing baseline spirometry to establish a reference point, ensuring no contraindications such as severe airflow obstruction, recent myocardial infarction, or uncontrolled hypertension exist. The safety of the patient is paramount throughout the procedure, necessitating the immediate availability of rescue bronchodilators, oxygen, and emergency medical equipment in the testing suite. When executing the test, we generally follow one of two standardized protocols: the 2-minute tidal breathing method or the 5-breath dosimeter methodology. In the tidal breathing technique, the patient inhales an aerosol of methacholine at increasing concentrations for 2 minutes while resting, followed by sequential spirometry measurements. Conversely, the dosimeter method provides a precise, controlled volume of aerosol via a nebulizer triggered by the patient's inspiratory effort, which often yields greater accuracy in dose-response mapping. We track the forced expiratory volume in 1 second, FEV1, after every step. Our primary objective is to identify the precise provocative concentration or dose that induces a 20% decline from the post-saline baseline. This calculation is vital because it quantifies the degree of reactive dysfunction within the bronchial smooth muscle. Maintaining a steady pace is essential, yet accuracy must never be sacrificed, as the timing between doses and the subsequent spirometric attempts must strictly adhere to the established ATS guidelines to validate the resulting provocation concentration. Managing the progression of the test requires constant vigilance regarding the patient's clinical state and the recorded trend of their FEV1. If the FEV1 falls below the 20% threshold, the challenge is immediately terminated, and a bronchodilator is administered to reverse the induced bronchospasm. We must observe the patient for a specific recovery interval to ensure that lung function returns to within 10% of the baseline value before they are discharged. In cases where the patient demonstrates exercise-induced bronchospasm, the profile differs slightly, focusing on the changes in airflow obstruction following a structured period of physical exertion rather than chemical inhalation. This requires simulating an exercise environment that challenges the airways adequately, often requiring a heart rate target or specific ventilation threshold to be met during the trial. Documenting the recovery phase after exercise is equally critical, as the peak fall in FEV1 often occurs several minutes after the conclusion of the activity, reflecting the specific physiological response of the airway to thermal and osmotic stress. Technicians must be meticulous when preparing serial dilutions of methacholine, as the accuracy of the provocative dose depends entirely on the correct concentration of the pharmacological agent. We calculate these concentrations using a doubling sequence, starting from a baseline saline control and moving upward to the maximum protocol dosage. Errors in chemical preparation can lead to inaccurate diagnostic conclusions, potentially resulting in misdiagnosing patients or failing to identify symptomatic asthma. Every step must be performed under strict quality control standards to ensure that the nebulization output and the dosage inhaled reflect the intended scientific protocol. By carefully mapping the dose-response relationship, we provide physicians with the objective data required to prescribe effective long-term controller medications or confirm the need for further investigation of atypical respiratory symptoms. This systematic rigor minimizes subjectivity and elevates the clinical utility of the laboratory, ensuring the integrity of the data collected during these complex diagnostic challenges. See you in the next lecture. Welcome to the chapter on field walking tests, where we will examine the precise execution and clinical management of functional capacity assessments. In this session, we will focus on standardized protocols to ensure your data collection meets the rigorous expectations of the RPFT examination. Field walking tests such as the 6-minute walk test, or 6MWT, and the incremental shuttle walk test are fundamental tools for evaluating a patient's functional exercise capacity. Unlike controlled cardiopulmonary exercise testing, these field tests reflect how a patient performs during activities of daily living. The 6MWT is a submaximal exercise test that provides a surrogate measure of endurance, typically conducted in a flat, enclosed corridor of at least 30 meters in length. You must ensure the course is measured accurately, as improper track distances directly invalidate the final distance calculation. Markers placed every 3 meters serve as clear visual aids for both the technologist and the patient to track progress during the walk. Consistent application of these physical parameters is the primary defense against systemic error in your diagnostic reporting. Standardization is the cornerstone of these tests, particularly regarding the verbal coaching provided to the subject. The American Thoracic Society and other governing bodies provide specific scripts to ensure that encouragement does not inadvertently alter the patient's pace or effort level. You must deliver these commands at standardized intervals, such as every minute, using a neutral and encouraging tone without adding personal variation. Variations in coaching style can lead to significant discrepancies between tests, effectively creating noise in your clinical data. During the test, you must focus on monitoring the patient's pulse oximetry, looking specifically for sustained desaturation events that might signal a need to stop the procedure. Always remember to capture the Borg dyspnea scale score at the start and immediately upon the completion of the walk to quantify the patient's perceived exertion. Managing a patient during the walk requires a fine balance between steady supervision and non-interference with their natural gait. If a patient requires supplemental oxygen, You must be proficient in titrating the flow rate based on the pre-established clinical protocol or the observed desaturation patterns during the walk itself. This involves carefully managing the oxygen tubing to avoid trip hazards while ensuring adequate flow throughout the duration of the exertion. You are also responsible for identifying the clinical indicators that mandate immediate test termination, such as chest pain, intolerable dyspnea, or severe dizziness. A patient might attempt to vary their pace, often speeding up or slowing down. Your role is to ensure they remain consistent without providing pacing signals that are not supported by the standardized protocol. Documentation must be meticulous, capturing the total distance walked, the level of perceived exertion, any oxygen supplementation required, and the specific reasons for any test pauses or early terminations. The incremental shuttle walk test, or ISWT, differs from the simple 6MWT by requiring the patient to walk back and forth at an increasingly faster pace in response to audible signals. This test is effectively an external pacer, which removes the need for you to control the speed manually, yet it requires a different set of management skills. You must be prepared to manage the audio equipment and ensure the signals are clearly audible throughout the entire length of the corridor. The failure to maintain the required speed for 2 consecutive shuttles is the standard criterion for terminating the ISWT. Because this is an incremental test, the cardiovascular demand is higher, making the monitoring of pulse oximetry and heart rate even more critical than in a standard fixed-distance test. Your focus must remain on the patient's physical response to the increasing demand while ensuring that all safety protocols for emergency intervention are kept within immediate reach. When interpreting the results, always correlate the distance covered with the patient's baseline pulmonary function values and their clinical history. A drop in oxygen saturation during exertion that recovers rapidly upon cessation is a distinct finding from a desaturation that persists or requires a significant volume of rescue oxygen. Always record the Borg scale values accurately, as a patient who walks a significant distance with a low dyspnea score presents a very different clinical picture than one who barely finishes the test with a maximal score. The integrity of your documentation serves as the objective record that physicians use to make therapeutic decisions, such as prescribing home oxygen or evaluating the efficacy of a pulmonary rehabilitation program. By strictly adhering to these standardized protocols, you minimize the variability inherent in human performance testing. This systematic approach is exactly what the RPFT board expects when testing your competency in field diagnostics. See you in the next session. Welcome back, everyone. In this lesson, we will examine the protocols for specialized challenge tests, specifically high-altitude simulation and the assessment of exhaled nitric oxide. High-altitude simulation tests, often referred to as hypoxic challenge tests, serve a critical clinical purpose by mimicking the reduced partial pressure of oxygen experienced during commercial air travel. When patients with underlying pulmonary disease prepare for flight, we must determine if they require supplemental oxygen to maintain adequate arterial saturation. We perform this by blending oxygen and nitrogen to reach an inspired fraction of oxygen, or VO2, of 15%. This concentration mirrors the pressure conditions found in a pressurized aircraft cabin, typically maintained near an equivalent altitude of 8,000 feet. Accuracy is paramount during this procedure, so we must verify the blended gas mixture using an external oxygen analyzer before allowing the patient to breathe from the circuit. We monitor the patient continuously throughout the simulation, focusing on arterial oxygen saturation, heart rate, and symptomatic reports of dyspnea or lightheadedness. If a patient's oxygen saturation drops below 85% during this hypobaric simulation, it is a clinical indicator that supplemental oxygen is indicated for their flight. The management of specialized breathing circuits during environmental stress simulations requires a rigorous commitment to preventing hypoxia-related artifacts. We must ensure that the patient remains calm and that the seal of the delivery mask or mouthpiece is maintained throughout the challenge to avoid entrainment of room air. During the challenge, we also track cardiac adaptations, noting that tachycardia often accompanies the onset of physiological stress in these atmospheric simulations. The safety of the patient is our absolute priority, which is why technicians must be prepared to terminate the simulation immediately if the patient shows signs of significant distress or if saturation levels fall below critical thresholds. We must also carefully document the baseline room air saturations before initiating the hypoxic gas mixture. By standardizing these parameters, we create a reproducible environment that provides a reliable assessment of a patient's flight safety. Beyond hypoxic challenges, we frequently utilize the measurement of fractional exhaled nitric oxide, often abbreviated as FeNO, to provide a non-invasive look at airway inflammation. This procedure relies on either chemiluminescent or electrochemical sensors to quantify the concentration of nitric oxide within the exhaled breath. Because nitric oxide is a marker for eosinophilic inflammation in the airways, these measurements offer valuable insights for patients who may have asthma or other inflammatory conditions. To obtain a valid measurement, the patient must maintain a steady expiratory flow rate, generally held at 50 milliliters per second for a specified time interval. This flow rate is significant because the concentration of nitric oxide in the exhaled air is flow dependent. It is higher at lower flow rates and lower at higher flow rates. Therefore, coaching the patient to maintain a consistent, controlled exhalation is perhaps the most difficult and vital aspect of the test. Successful testing requires us to pay close attention to environmental and dietary variables that could potentially confound our nitric oxide results. Nitrates found in food, such as leafy greens, beets, or processed meats, have been reported to influence FeNO levels, so we advise patients to abstain from high nitrate foods for several hours prior to their visit. We also ensure that the testing environment is clean and free from elevated ambient nitric oxide, which could artificially raise the baseline and mask the patient's actual airway data. During the actual maneuver, the monitoring software usually provides real-time feedback to guide the patient, helping them to maintain the required constant expiratory flow. If the patient fails to keep the flow within the acceptable range, the measurement may no longer reflect the underlying eosinophilic status of the lungs. By controlling these variables, we ensure that our data accurately distinguishes between phenotypes of airway obstruction, which is essential for guiding corticosteroid therapy. Integration of these specialized tests into your clinical repertoire demands a high level of technical precision and vigilance. You are effectively acting as the gatekeeper for patient safety and clinical diagnosis when managing these complex maneuvers. Always double-check your gas blending calculations before initiating any hypoxic simulation to prevent accidental delivery of inappropriate concentrations. Similarly, when performing exhaled nitric oxide testing, document any recent respiratory infections or changes in medication, as these can significantly alter inflammatory markers. Mastering these procedures will enhance your diagnostic capabilities and ensure that your pulmonary function laboratory operates at the highest standard of evidence-based practice. I will see you in the next lecture. Welcome back. We are now turning our focus towards the Advanced Diagnostic System Synthesis chapter to bridge the gap between isolated test results and comprehensive clinical patient narratives. This chapter is designed to transition your skill set from performing individual tests to synthesizing diverse diagnostic datasets into a cohesive clinical overview. In this session, we examine the synthesis of complex metabolic, provocative, and interventional testing profiles, which is essential for any practitioner aiming to master comprehensive pulmonary diagnostics. When we look at a patient's case, we often start with baseline mechanics, but these values rarely tell the full story when the respiratory system is subjected to the physiological stresses of daily life or specific disease states. The challenge lies in our ability to cross-compare these baseline mechanics with actual stress performance indicators observed during cardiopulmonary exercise testing. For instance, a patient might demonstrate normal spirometric values at rest, yet reveal significant ventilator inefficiency or exertional hypoxemia during a graded exercise protocol. Understanding this discrepancy requires a deep dive into the mechanical constraints of the lung versus the gas exchange efficiency at the alveolar capillary membrane. By correlating resting blood gas indices with exercise oxygenation parameters, we can pinpoint whether the patient's limitations stem from ventilation-perfusion mismatch, diffusion impairment, or cardiac-related limitations. This integration is not merely an academic exercise. It is the fundamental process by which we characterize the severity and underlying mechanism of respiratory failure or exercise intolerance. Moving beyond exercise-related data, we must also address the intricate task of charting bronchial hyperresponsiveness alongside structural abnormalities that might already be evident on imaging or baseline lung volume testing. It is tempting to consider bronchial provocation tests as standalone diagnostics, but they must be interpreted within the context of the patient's overall structural health. If a patient exhibits fixed airway obstruction, the provocative response may be masked or skewed, requiring the technologist to exercise clinical judgment in data reporting. Similarly, when we analyze obstructive patterns, we need to balance the findings of flow volume loops with static volumes and diffusion capacity to form a reliable clinical picture. The synthesis of these multimodality datasets allows us to distinguish between various pathologic states that might otherwise present with ambiguous flow volume configurations alone. Our responsibility is to ensure that the data we provide to the consulting physician is not just accurate in its raw form, but also formatted in a way that suggests a clear logical progression of the underlying disease process. Effective diagnostic synthesis also mandates that we track therapy response metrics over time, which provides a longitudinal perspective that informs future treatment strategies. When a technologist is tasked with documenting the impact of a bronchodilator or a rehabilitation intervention, the technical precision of the repeat measurement is as vital as the initial diagnostic testing. We need to evaluate complex cardiovascular pulmonary boundary conditions, such as determining if an increase in dyspnea is related to poor gas exchange or potentially occult cardiovascular pathology exposed during physical exertion. This requires the technologist to maintain an acute awareness of the signs of hemodynamic instability that can occur during metabolic testing. By consolidating pulse oximetry, capnography, and gas analysis data into a structured summary, we provide the diagnostic consultation team with the necessary granularity to make informed clinical decisions. This is where your attention to calibration, quality control, and procedural adherence pays off, as any error in the initial datasets will propagate through the entire synthesis, potentially leading to erroneous clinical conclusions. Consider the diagnostic profile of a patient presenting with unexplained exertional dyspnea, where resting spirometry is within normal limits. In such cases, the synthesis process dictates that we examine the alveolar arterial oxygen gradient during exercise to see if it widens disproportionately, which would signal a diffusion issue that was hidden at rest. We must also analyze the breathing pattern, noting the respiratory rate and tidal volume relationship to detect inefficient mechanical breathing patterns that may not be captured by a simple flow volume loop. Integrating these disparate data points requires an understanding of the interplay between the circulatory and respiratory systems, as this is where the most critical diagnostic information often resides. When we compile these metrics for physician review, we are acting as the primary gatekeepers of data integrity, ensuring that the clinical overview accurately reflects the patient's physiological reality. This level of technical proficiency separates the competent technologist from those who merely collect data, providing the diagnostic precision needed in high-acuity environments. See you in the next lecture. Welcome to this chapter on pediatric growth and development, where we will examine the physiological nuances required for accurate diagnostic testing in younger patients. Mastering these concepts is essential for any RPFT, as pediatric patients are not simply miniature adults. Understanding the pediatric respiratory system begins with recognizing that the infant chest wall is significantly more compliant than that of an adult. Because the ribs are cartilaginous and lack the rigid structural support of ossified bone, the chest wall tends to collapse inward during inspiration. This requires the diaphragm to work harder to generate adequate negative pressure, which contributes to the rapid fatigue we often see in respiratory distress. As a technologist, you must appreciate that this high compliance reduces the functional residual capacity of the lung, meaning there is less reserve air to buffer against transient periods of apnea or airway obstruction. When interpreting data, remembering this structural mechanical disadvantage helps explain why even minor respiratory illnesses can lead to rapid decompensation in infants compared to adolescents or adults. Airway resistance in pediatric patients is governed by Poiseuille's law, which dictates that resistance is inversely proportional to the radius of the airway to the fourth power. In children, especially infants, the absolute diameter of the upper and lower airways is remarkably small, meaning a small amount of mucosal edema or inflammation can increase resistance exponentially. While an adult might tolerate a few millimeters of swelling without significant distress, The same degree of inflammation in a toddler can lead to life-threatening turbulent flow. This physiological reality forces us to be acutely aware of airway geometry shifts during testing, as even the minor presence of secretions can drastically alter flow volume loop morphology. Technologists must correlate these findings with the patient's age-derived predicted values to determine whether observed limitations represent true obstructive disease or simply the anatomical constraints of a developing airway. Metabolic demands in children further differentiate them from adults, particularly regarding oxygen consumption rates. Infants consume oxygen at roughly double the baseline rate of an adult relative to their body size, which leaves little room for error during prolonged diagnostic maneuvers. This elevated metabolic demand necessitates a faster baseline respiratory rate to maintain arterial blood gas homeostasis and support rapid growth. When performing pulmonary function tests, this necessitates a shorter window of patient cooperation and a greater risk of desaturation if the patient is stressed or agitated. We must also consider that the elastic recoil of the lungs is continually evolving throughout childhood as alveoli multiply and the interstitium matures. These age-dependent changes mean that the normal values we rely on for standardizing PFT results are highly dynamic, shifting significantly from the neonatal period through the completion of puberty. To bridge the gap between theory and practice, we use growth charts to establish context for every test result we generate. Instead of relying on a static frame of reference, we correlate observed lung volumes, flows, and diffusion capacity against the specific growth trajectory of the individual child. This involves recognizing that lung growth does not follow a perfectly linear path, as periods of rapid somatic growth often lead to transient dysynchrony between thoracic size and lung parenchyma development. By understanding these mechanical and metabolic shifts, you are better equipped to determine when test results indicate clinical pathology and when they reflect the normal developmental range. As we move forward into technical setup, your ability to integrate these physiological facts will ensure that your testing modifications are both safe and clinically meaningful. I look forward to our next session. Welcome to this exploration of adapting pulmonary function equipment for pediatric and smaller patient populations. In this chapter, we focus on the technical adjustments necessary to maintain testing accuracy when standard adult configurations would otherwise introduce significant measurement error. When we transition from adult subjects to smaller patients, our default assumption is often that the equipment will scale down automatically, but this is rarely the case. Standard pulmonary function testing hardware is designed with specific volumes and resistances that assume a certain lung capacity and flow rate. When these systems encounter the smaller tidal volumes and faster relative flow dynamics of a child, the standard hardware creates an environment prone to rebreathing. We combat this by implementing low-resistance, low dead space breathing valves, which are critical to preventing the patient from inhaling their own exhaled carbon dioxide. This rebreathing artifact can falsely lower the measured oxygen partial pressure and distort the measured ventilation, leading to invalid diagnostic data that could compromise clinical decisions. The choice of pneumotachometer is equally significant when we consider the physics of digital signal resolution. A sensor that is oversized for the patient's flow range often suffers from a reduced signal-to-noise ratio because the sensors are unable to detect the subtle, low-flow variations characteristic of smaller airways. By selecting a smaller diameter pneumotachometer, we increase the velocity of the airflow across the sensor, which effectively optimizes the digital resolution and ensures that even minor shifts in flow are captured with precision. This hardware change forces a necessary revision of our circuit software configurations. We must ensure the software is calibrated to interpret these faster pressure changes and recognize the modified physical characteristics of the smaller transducer. Otherwise, the integration of flow to volume will result in cumulative drift and inaccurate spirograms. Plethysmography presents its own distinct set of challenges, specifically regarding the physical volume of the testing chamber. A large plethysmograph cabin contains a substantial amount of air that must be thermally stabilized before accurate thoracic gas volume measurements can be reliably gathered. When testing a small child, the relative displacement of body volume is minor compared to the total cabin volume, which can make the signal detection less sensitive. We mitigate this by utilizing properly sized seating inserts or foam blocks to displace the extra air within the cabin, effectively reducing the internal volume and narrowing the sensitivity range. This adaptation brings the cabin back into a working range, where the pressure-volume relationship remains linear and highly responsive to the child's efforts. Beyond the physical hardware, we must account for the dynamics of gas analysis within the internal circuitry. Standard gas analyzers are often configured to sample gas at a rate that is perfectly appropriate for adult tidal volumes, but these rates can actually induce volume depletion in a child's circuit. If the analyzer pulls too aggressively from the patient's side, it can suck room air into the circuit or create a pressure gradient that interferes with the patient's expiratory effort. We must manually scale down the sampling gas flows to a level that provides a representative sample without physically altering the patient's breath-by-breath volume dynamics. This is a delicate balance of maintaining sufficient gas turnover to prevent water vapor condensation while ensuring the sampling process itself doesn't become a distractor to the patient's respiratory rhythm. Finally, we must adjust the digital filter constants within our software tracking suites to accommodate the physiological pacing of smaller lungs. Adult algorithms usually incorporate smoothing filters designed to ignore high-frequency noise that is expected during adult maneuvers. However, a child's breath can involve rapid flow changes and higher frequencies that these standard filters might inadvertently interpret as baseline noise. By adjusting the digital filter constants to a wider passband, we ensure that the system captures the true, high-frequency respiratory events rather than flattening out the data. This level of technical oversight is what separates a routine test from one that is physiologically meaningful, ensuring that the technology supports the patient rather than hindering their ability to provide an objective, data-rich effort. See you in the next lecture. Welcome back. In this lesson, we will focus on the unique instructional and technical requirements for performing valid spirometry maneuvers in the pediatric population. Testing young children requires a significant departure from standard adult protocols because anatomical differences and cognitive development levels preclude the simple instruction of deep inhalation followed by a 6-second blast. The primary objective is to gain the child's cooperation through play-based coaching while ensuring the physiological requirements for a valid forced expiratory loop are met. Most modern software suites include visual incentive animations that react in real time to flow and volume changes, which serve as essential tools to capture a child's limited attention span and sustain their effort. When a child sees a birthday candle flickering or a race car moving on the screen, they are more likely to exert the necessary force to hit the target volume. However, the technician must balance this engagement with the critical requirement of rapid, explosive initiation, as hesitation frequently leads to suboptimal peak expiratory flow readings. The criteria for test termination undergo a necessary transition when dealing with children under the age of 10, as many cannot sustain a forced exhalation for the standard 6 seconds requested of adults. In pediatric settings, we often adjust the required expiration time down to 3 seconds, or even a single second for very young patients, provided that an end-of-test plateau is clearly achieved. Assessing this plateau requires a keen eye because the rapid decay in flow seen in young children might be mistaken for an early termination of effort. You must verify that the volume time curve demonstrates a leveling off, confirming that the child has emptied their lungs to the extent of their current physiological capability. If the flow drops to near zero while the volume remains constant, the maneuver is typically considered acceptable regardless of the total elapsed time. Maintaining a proper seal during the maneuver presents another hurdle, particularly when using standard mouthpieces that are too large for smaller facial structures. Using pediatric-sized mouthpieces reduces the dead space and makes it physically easier for the child to maintain an airtight seal, drastically minimizing the risk of leaks around the corners of the mouth. You must also pay close attention to nasal seal integrity, ensuring that nose clips are placed securely without causing undue discomfort that might distract the child or cause them to pull away from the sensor. If a leak is detected, it is almost always better to pause, recalibrate the interaction, and start fresh than to attempt to salvage a compromised curve. A constant vigil on the loop shape is necessary to identify variable effort patterns, which are common in this group and often manifest as a sawtooth appearance or a prematurely blunted peak flow. Because pediatric patients may exhibit inconsistent effort across multiple attempts, we apply modified reproducibility limits that acknowledge the natural variance in their performance. While the standard adult guidelines require that the two largest forced vital capacity and forced expiratory volume in 1 second values be within 150 milliliters of each other. These strict criteria are often relaxed for children to account for their smaller lung volumes. As a technician, your role is to identify if the variability is due to true effort fluctuations or a fundamental lack of understanding of the test. Rapid, forceful inspiratory efforts are just as vital as the exhalation. So ensure the child is adequately coached to take a rapid, complete inhalation from residual volume or functional residual capacity depending on the specific phase of the test. By integrating these technical adaptations, you ensure that the data collected are not only valid but representative of the child's actual pulmonary function, providing the physician with reliable information for clinical decision-making. See you in our next session. Welcome to this session on the technical adaptations required for pediatric lung volumes and diffusing capacity assessments. We will examine how to maintain precision while managing the unique physiological and behavioral constraints of young patients. Testing lung volumes and diffusion in children demands a shift from standard adult protocols because of the smaller anatomical structures and shorter respiratory cycles. When using helium dilution or nitrogen washout, the primary challenge involves the rapid equilibration constant caused by higher respiratory rates and smaller functional residual capacities. You must be prepared to adjust your tracer gas volume and recalibrate the system dead space to account for pediatric interfaces, since the internal equipment volume can significantly skew results if not properly accounted for. A standard adult mouthpiece or circuit often introduces too much mechanical dead space, which leads to artificial hypercapnia or rebreathing patterns in a small child. When observing the gas concentration curves, you should watch for premature completion of the test where the child's lack of patience or high respiratory frequency forces a false equilibrium plateau. Precision here relies on your ability to verify that the wash-in or wash-out phase truly represents the entire lung volume rather than just tidal distribution. Body plethysmography presents its own distinct set of hurdles with pediatric patients, primarily centering on the rapid shutter maneuvers required for thoracic gas volume measurement. You are essentially asking a child to perform an inspiratory effort against a closed shutter while they are likely experiencing anxiety or discomfort in the enclosed cabin. Success requires consistent coaching that mimics the child's natural language, ensuring they understand the necessity of the panting and the momentary occlusion event. You must remain vigilant for leaks around the facial seal, as a poor fit during the panting maneuver will cause the volume readings to fluctuate uncontrollably. If the child breaks the seal, the pressure-volume relationship within the box is compromised, and you must restart the measurement from a baseline pressure normalization. Tracking the baseline drift during the panted breaths is crucial because even minor fluctuations in their seating position or crying can introduce significant noise into the transpulmonary pressure calculations. The single-breath diffusing capacity test in pediatrics is notoriously difficult due to the requirement for a precise, sustained breath hold. In an adult, a 10-second hold is routine, but for a child, this duration might feel like an eternity, leading to glottal closure issues or premature exhalation. You must adapt your monitoring to identify when the child has achieved a sufficient vital capacity intake before the timer starts, as an incomplete inspiration invalidates the diffusion capacity calculation. If the child fails to maintain the breath hold, you need to rely on your visual cues to determine if the subsequent alveolar gas sample has been contaminated by tidal air. It is often necessary to offer a more encouraging and rhythmic verbal cadence during the intake phase to ensure they hit the required volume thresholds. You must also be prepared to calculate the correction for smaller lung volumes, as the diffusing capacity values will inherently be lower and require interpretation against age, height, and gender-specific reference equations. Anxiety behaviors often disrupt the entire test sequence and can be misinterpreted as physiological limitations if you are not careful. Pediatric testing is as much about psychological management as it is about physiological measurement, so your ability to remain calm and authoritative dictates the quality of the data. If a child begins to hyperventilate or demonstrate signs of distress, your priority shifts to resetting their breathing rhythm before attempting any maneuver that involves gas equilibration. Remember that equipment recalibration is not a one-time process when dealing with multiple small patients in succession, as residual gas from a previous test can easily hide in small bore circuits. By staying focused on the physical manifestations of the child's breathing pattern, you can catch artifacts immediately and adjust the procedural steps to ensure the final data is both accurate and reflective of the patient's actual respiratory status. See you in the next session. Welcome to this exploration of specialized pediatric asthma protocols and provocation testing. We will cover the technical and safety nuances required to successfully perform these sensitive evaluations in a growing population. Testing children for airway hyperresponsiveness demands a shift in both hardware configuration and clinical oversight. Unlike adult protocols, pediatric provocation necessitates child-friendly delivery circuits that minimize dead space while accommodating shorter, more rapid inspiratory cycles. When utilizing methacholine for bronchial challenge testing in youth, clinicians must adopt more conservative dose schedules to account for the unique reactivity profiles of smaller airways. Prior to initiating any provocation sequence, you must establish clear safety parameters for identifying severe hyperresponsiveness early in the cycle, which often requires a lower initial dose than the standard adult 0.03 mg per milliliter starting point. Furthermore, the technologist must monitor clinical indicators of respiratory distress with heightened vigilance, as pediatric patients may manifest distress through accessory muscle use or increased respiratory rate long before formal spirometric signals of obstruction reach critical thresholds. Managing the psychological component of testing is as vital as the technical execution of the maneuver. Parents often experience significant anxiety during challenge procedures, which can unintentionally influence the child's performance and cooperation. As a technologist, your ability to provide clear, reassuring communication to the family while maintaining your own objective focus is essential for obtaining valid, effort-dependent data. You must ensure that rapid rescue access, including bronchodilators and clinical support, is immediately available within the testing suite. Establishing a rapport that encourages the child to perform the necessary maneuvers without undue pressure allows for a more accurate reflection of their true airway state. When the child reaches their clinical peak, the ability to transition smoothly into the post-challenge recovery phase demonstrates the professional competence expected of a registered technologist. Evaluating the pediatric response to provocation also requires a nuanced understanding of wheezing variants in small airway responses. Standard markers like the FEV1 are necessary, but they may not tell the whole story. You must look toward alternative flow parameters like the FEF 25 to 75 or specific portions of the expiratory flow volume loop to detect early patterns of small airway constriction. These parameters can be particularly sensitive in children where large airway obstruction may not yet be dominant. If the child shows a decline in these flow parameters early in the protocol, recognize this as a potential lead indicator for an approaching FEV1 threshold exceedance. Always document the qualitative nature of sounds heard during expiration, as these wheezing patterns often provide context for the numeric changes seen on your spirometer. Interpreting these results within the broader context of the child's growth and development ensures that the diagnostic data is both clinically relevant and technically sound. I look forward to our next discussion on pediatric data validation parameters. Welcome back to our discussion on navigating the intricacies of pulmonary function testing for younger populations. This lesson focuses specifically on the technical and behavioral requirements for validating pediatric test acceptability in a clinical setting. When we approach pediatric pulmonary testing, we must operate under the understanding that children are not merely smaller adults. The Global Lung Function Initiative, or GLI, provides the standardized framework we rely upon to interpret these measurements effectively. These reference equations are critical because they account for the rapid, nonlinear changes in lung growth that occur throughout childhood. If we fail to select the correct demographic and anthropometric inputs, such as age, height, and ethnicity, our reference values become medically irrelevant. The lower limit of normal, often abbreviated as LLN, is our primary statistical tool for identifying obstruction, as it remains more robust than a fixed 80% of predicted value across varying age groups. We must remember that as children grow, their lung volumes increase exponentially, meaning that even minor discrepancies in measurement can lead to significant diagnostic errors. Beyond the statistical framework, we encounter the technical challenge of expiratory maneuvers that often appear incomplete or suboptimal. In an adult, we demand a 6-second exhalation to ensure the full volume of the lung is assessed, but pediatric patients frequently struggle to maintain this effort due to cognitive or physiological constraints. Our role is to distinguish between a test that is technically imperfect due to the child's developmental stage and one that is clinically invalid. We evaluate the flow volume loop for specific markers of effort, such as the back extrapolated volume and the consistency of peak expiratory flow. When maneuvers are short, we look for an identifiable plateau in the volume time curve that signifies the child has reached their functional capacity, even if the duration is shorter than standard adult benchmarks. If we cannot reach a true plateau, we must document the maneuver as an incomplete effort rather than a technical failure of the equipment. Documenting behavioral compliance is an essential, yet often overlooked, component of quality assurance in the pediatric laboratory. You should assign an acceptability score that reflects both the technical quality of the curve and the patient's cooperation level throughout the session. This dual-layered reporting is vital for the pediatric pulmonologist who receives these results, as it provides context for why a specific test might lack the classic morphological features of a perfect loop. If a child is distressed or unable to follow coaching, that narrative must accompany the raw data to prevent clinicians from misinterpreting a behavioral limitation as a restrictive pulmonary pattern. By recording whether the test was obtained through play-based encouragement or direct instruction, we add a necessary layer of qualitative data to the quantitative measurements. Finally, we must integrate these findings into the clinical report, paying close attention to somatic growth anomalies that deviate from standard developmental trajectories. Conditions like scoliosis, achondroplasia, or severe malnourishment can distort the predicted reference calculations if we assume the patient follows a standard height to long size ratio. When the patient's standing height is unreliable, we might use arm span or sitting height as a surrogate, provided we clearly annotate this in the final report. Our objective is to ensure that the data shared with the ordering physician is both accurate to the equipment and representative of the child's true physiological state. Synthesizing this information allows the clinical team to track lung function trends over time with far greater confidence, ensuring that developmental shifts in the respiratory system are correctly distinguished from potential pathologies. Until we meet again for the next lecture. Welcome to this module on analyzing pulmonary function test results against demographic predicted values. We will focus on moving beyond outdated benchmarks to achieve precision in clinical interpretation through modern statistical applications. When we analyze pulmonary function data, we essentially attempt to determine if a patient's results fall within the range of healthy individuals of similar demographics. Historically, clinicians relied on fixed thresholds, such as expressing results as a percentage of the predicted value. While this provided a simple heuristic, it failed to account for the inherent biological variability that scales differently across various ages, heights, and genders. By moving toward the use of z-scores, we gain a more robust statistical framework. A z-score represents the number of standard deviations a measured value lies from the predicted mean of a reference population. This approach is superior because it normalizes data according to the distribution of the reference group, allowing for a standardized interpretation of physiological variance across different age brackets or ethnicities. The choice of a reference equation database is perhaps the most significant decision a laboratory makes regarding data integrity. If the demographics of your local patient population do not align with the reference group that generated a specific equation, your diagnostic findings will inherently skew. For instance, multi-ethnic reference equations, such as those provided by the Global Lung Function Initiative, seek to mitigate these variances by providing a more inclusive statistical baseline. We must reject the use of outdated fixed percentages because they often result in false negatives for shorter or older individuals and false positives for taller or younger ones. The lower limit of normal, or LLN, defines the 5th percentile of the healthy population and offers a more scientifically defensible boundary for identifying pathology compared to an arbitrary 80% cutoff. If a patient falls below the LLN, we have a statistically sound basis to suggest a non-normal finding, as this threshold accounts for the expected dispersion of data. Technologists frequently encounter scenarios that challenge our data collection, specifically involving physical deformities or extreme anthropomorphic cohorts. Accurate stature is the single most important variable in predicting lung volume and flow parameters. When scoliosis, kyphosis, or other spinal deformities prevent a patient from standing erect, we must use arm span measurements as a proxy for height. However, applying a standard conversion factor to arm span is not always universal across diverse ethnic groups, and subtle errors here can cascade through your calculations. Furthermore, we must exercise caution when extrapolating reference equations to patients whose characteristics lie at the extreme ends of the distribution. Statistical models are generally most reliable within the core range of their original dataset. Moving into extreme age or height cohorts introduces uncertainty that the equations were never designed to manage. Evaluating individual variances requires us to distinguish between normal biological fluctuation and true clinical significance. Every PFT result inherently carries some degree of measurement noise, influenced by both equipment calibration and patient effort. When we interpret these values, we are looking for deviations that exceed the expected statistical margin of error for that demographic. This is why understanding the shape of the distribution for a given reference population is critical. A narrow distribution means that even a small deviation might be clinically significant, whereas a broad distribution suggests higher variability is normal. By focusing on z-scores and the LLN, we shift our role from mere data recorders to analysts who provide contextually accurate information to the interpreting physician. Maintaining this rigor ensures that the laboratory remains a pillar of reliable diagnostic support within the larger healthcare system. We'll see you in the next session. Welcome back. In this chapter, we will master the interpretation of complex, overlapping pulmonary pathologies by synthesizing disparate datasets. To begin our analysis of complex pathophysiologic states, we must first address how to disentangle mixed obstructive and restrictive patterns. When a patient presents with both a reduced forced vital capacity and a reduced FEV1 to FVC ratio, we are looking at a classic mixed disorder. However, simply identifying this is insufficient for a professional exam. You must look at the total lung capacity as your primary differentiator. If the total lung capacity is elevated or normal while the airflow is obstructed, we are likely looking at hyperinflation related to emphysema. But if the total lung capacity is genuinely reduced alongside obstruction, the coexistence of a restrictive process like interstitial disease becomes the working hypothesis. It is this systematic cross-referencing between lung volumes and expiratory flow rates that allows us to move beyond elementary patterns into advanced diagnostics. Early small airway disease represents one of the most subtle challenges in pulmonary function testing because it often does not manifest in the standard indices used to diagnose moderate or severe obstruction. We look specifically at mid to late expiratory flows, such as the FEF 25 to 75%, to catch these early-stage physiological changes before the FEV1 itself has moved outside of the normal range. When investigating this, you must be cautious about technical artifacts, which can frequently mimic the curvilinear shape of small airway obstruction. A patient who does not perform a full effort or who experiences premature glottis closure will produce a flow volume loop that looks suspiciously like a small airway disease manifestation, even when the lung parenchyma is completely healthy. You must insist on reproducible and effort-dependent flows to ensure that we are interpreting patient biology rather than laboratory error. Neuromuscular weakness frequently presents in pulmonary function data as a restrictive pattern, yet the mechanism is entirely distinct from interstitial lung disease. When assessing these patients, the key indicator is a significant reduction in the maximum inspiratory and expiratory pressures, which are often mirrored by a reduction in lung volumes without a corresponding shift in the diffusing capacity. In contrast, if you were dealing with true parenchymal restriction, the diffusing capacity would almost certainly be reduced as well. You should always look for the relationship between the vital capacity and the maximum pressures. If the vital capacity is disproportionately low compared to what the body mass and height would predict, but the airways remain patent and the alveolar capillary surface area is preserved, suspect a neuromuscular bottleneck that limits the patient's ability to inflate the lungs fully. Pulmonary vascular limitations reveal themselves through the specific correlation between diffusing capacity and lung volumes. When the diffusing capacity for carbon monoxide is significantly lower than what would be predicted by the loss of lung volume, we must evaluate the possibility of vascular pathology. If the lung volumes are relatively preserved but the diffusing capacity is isolated in its reduction, this is a strong signal of pulmonary vascular disease or pulmonary hypertension. You must synthesize this with the patient's clinical history, as a healthy lung volume with a low diffusing capacity is a classic presentation that requires careful differential consideration. It is the mismatch between the integrity of the lung structure, as shown by volumes, and the effectiveness of the gas exchange surface, as shown by carbon monoxide uptake, that provides the necessary evidence for this clinical conclusion. When we encounter conflicting diagnostic signals, our role is to act as a filter that separates actual physiological impairment from data degradation. Technical artifacts, such as leaks during plethysmography or submaximal efforts, frequently cloud the true picture. If your data indicates a restrictive defect, but the flow volume loop shows concave features or mid-flow dipping, you must revisit the calibration data and the patient's effort quality before rushing to a diagnosis. Objective interpretive summaries for physicians should prioritize the most physiological plausible explanation while highlighting the limitations of the data if the testing conditions were suboptimal. This requires a professional demeanor where you clearly state the findings, note any discrepancies, and suggest which specific tests, if any, should be repeated to clarify the ambiguous signals encountered during the initial evaluation. See you in the next lesson. Hello, and welcome to this session on patient preparation protocols. We will explore the critical communication strategies and clinical requirements necessary to ensure optimal patient adherence before diagnostic pulmonary function testing. Effective patient preparation begins long before the patient arrives in the laboratory, as the reliability of our data depends entirely on the patient's compliance with these specific instructions. When we ask a patient to withhold bronchodilators, we are attempting to eliminate variables that could artificially mask obstructive patterns or alter the results of bronchodilator reversibility testing. Short-acting bronchodilators, such as albuterol, typically require withholding for at least 4 to 6 hours, while long-acting agents like salmeterol or tiotropium may necessitate a cessation period of 24 to 48 hours to ensure an accurate baseline. Failing to communicate these timeframes clearly often leads to suboptimal data that we cannot reliably interpret. You must provide these instructions in a format that the patient understands, ensuring they know exactly how to manage their medication regimen without compromising their personal safety. Always verify that the patient has actually adhered to these windows by performing a medication reconciliation immediately upon their arrival at the facility. If a patient has taken medication prematurely, you must decide whether to proceed or reschedule, bearing in mind the potential impact on the diagnostic integrity of the specific test being performed. Beyond medications, we must also address nutritional and environmental intake, particularly for specialized procedures like metabolic testing or bronchial provocation challenges. Caffeine, for instance, acts as a mild methylxanthine bronchodilator and can definitively interfere with the physiological response we expect to observe during challenge testing. Patients should ideally refrain from caffeine for at least 4 to 6 hours prior to these procedures to avoid creating a false negative response. Similarly, large meals can impact metabolic measurement results by shifting the respiratory exchange ratio or causing physical discomfort that restricts full deep inhalation into total lung capacity. We must be explicit about the difference between light refreshments and a full caloric intake. Activity limits are equally important, as significant physical exertion immediately before a diagnostic procedure can lead to premature dyspnea or tachycardia. By establishing these boundaries, we standardize the patient's state, making the physiological data we collect far more representative of their underlying disease process rather than a reaction to recent habits. The screening process represents our last line of defense against adverse events, requiring you to identify absolute or relative contraindications before any maneuver begins. A recent myocardial infarction or unstable angina presents a significant risk, as the intrathoracic pressure generated during forced maneuvers can trigger cardiac instability. Similarly, patients with recent abdominal or thoracic surgeries, or those known to have significant thoracic or abdominal aneurysms, face risks related to pressure-induced rupture or wound dehiscence. Your assessment must incorporate a structured review of the patient's medical history to detect these red flags. If a patient falls into one of these high-risk categories, you are obligated to consult with the ordering physician before proceeding with testing that requires forced expiration. It is not sufficient to simply ask if they feel well. You must document that you have screened for specific clinical events that would preclude the maneuvers we are about to request. Protecting the patient from harm is the primary concern, and rigorous pre-test screening is the only way to satisfy this duty of care. Reducing patient anxiety through effective communication is a practical requirement for obtaining high-quality data during complex maneuvers. When a patient understands the logic behind the test, they are significantly more likely to provide the sustained, reproducible effort required for accurate spirometry or plethysmography. Start by explaining the purpose of the test in plain language, avoiding technical jargon that might confuse or overwhelm an already anxious individual. Use clear demonstrations, acting out the required maneuvers without the equipment to help internalize the expected rhythm of the test. A patient who is calm and well briefed can better follow the complex instructions regarding breath holding or the forcefulness of their exhalation. Furthermore, be attentive to physical limitations such as back pain or orthopedic issues, which might prevent a patient from sitting upright or utilizing a nose clip effectively. By addressing these physical constraints with supportive seating or alternative techniques, you manage the patient's comfort and keep the focus on achieving the diagnostic goals. See you in the next session. Welcome back. Today, we are shifting our focus toward the critical domain of infection control and safety protocols within the pulmonary function testing suite. This chapter is designed to ensure you understand how to protect both your patients and yourself by mastering the rigorous standards required in a clinical diagnostic environment. In the clinical setting, universal precautions serve as the foundational bedrock for all interactions involving bodily fluids and respiratory secretions. When you manage a pulmonary function laboratory, you must treat every patient as if they are potentially infectious, regardless of their known diagnosis or history. This means the consistent application of standard precautions, including the use of gloves, masks, and eye protection whenever there is a reasonable risk of exposure to aerosolized particles or droplets. Forced maneuvers, such as those performed during spirometry, generate significant turbulence and potential aerosolization of respiratory secretions that could harbor pathogens. You are not only safeguarding your own health, but also preventing cross-contamination between patients who move through your testing station throughout the day. By maintaining a strict barrier between the patient, the equipment, and the environment, you ensure that the integrity of the diagnostic space remains unimpeachable and safe for everyone involved. Decontamination cycles represent the technical implementation of our safety strategy, requiring a systematic approach to cleaning every component that contacts the patient. Breathing circuits, which are prone to moisture accumulation and colonization, must undergo validated chemical sterilization or, when appropriate, be replaced by single-use alternatives. When evaluating the efficacy of disposable filters, you must ensure that they meet the high bacterial and viral filtration efficiency standards required to block pathogens during peak expiratory flows. If a filter is used, it should be high resistance to pathogen passage while maintaining low enough resistance to airflow so as not to invalidate the pulmonary mechanics being measured. After a high-risk exposure, such as testing a patient with a confirmed multi-drug resistant organism, your laboratory must follow a documented decontamination protocol that includes surface disinfection with EPA-registered agents. This ensures that the physical equipment, from the pneumotachometer to the mouthpieces, is rendered safe before the next patient arrives for their evaluation. Laboratory air exchange requirements are often overlooked, yet they are essential for mitigating the concentration of aerosolized material in a testing room. You should be familiar with your facility's ventilation standards, which typically require a specific number of air exchanges per hour to ensure adequate dilution of airborne contaminants. In addition to air quality, the management of biohazard waste streams demands your constant vigilance and strict adherence to institutional and OSHA guidelines. Every item that has been in contact with patient secretions, including discarded mouthpieces and single-use tubing, must be handled as regulated medical waste. You must maintain these sterile boundaries, especially during invasive procedures like arterial blood gas sampling, where percutaneous exposure risks are elevated. Proper hand hygiene remains the most effective intervention. It must occur before and after every patient contact, effectively breaking the chain of transmission that persistent laboratory surfaces might otherwise foster. See you in the next lecture. Welcome to this chapter on the ethical and legal foundations of your clinical practice. We will navigate the critical boundaries and professional responsibilities that define your conduct as a registered pulmonary function technologist. In the diagnostic environment, your professional boundaries are not merely abstract concepts. They are the bedrock of the patient-provider relationship. Maintaining these boundaries requires a clear understanding of where your role as a technologist ends and where the clinical responsibilities of a physician begin. You are primarily responsible for the technical integrity of the test, which mandates that you refrain from providing definitive medical diagnoses or prognosis interpretations to the patient. While you must engage with the patient to ensure high-quality data collection, you should always maintain a neutral stance regarding their health outcomes. This ensures that you do not inadvertently influence the patient's anxiety levels or expectations before the referring physician has reviewed the formal report. By establishing these clear lines, you protect yourself from liability and ensure that the patient receives their medical information through the appropriate professional channel. It is a matter of discipline to focus purely on the objective measurements rather than subjective medical opinions. Informed consent is a pillar of ethical practice that often becomes a mere formality, but it requires your active verification at each encounter. Beyond simply having a patient sign a form, you must verify that they understand the nature of the pulmonary function test they are about to undertake, including any associated risks like syncope or bronchospasm. If a patient expresses hesitation or attempts to refuse a test, your duty is to facilitate communication between them and the ordering provider to address their concerns. Forcing a test on an unwilling participant is not only an ethical violation, but also a practical failure that will likely lead to suboptimal, non-diagnostic data. You must treat any verbalized refusal with respect, document it clearly in the medical record, and escalate the situation to the direct supervisor or the physician. Advocates for the patient must prioritize their physical and psychological comfort over the simple completion of a diagnostic profile. Privacy standards, particularly those mandated by federal regulations such as HIPAA, govern how you handle every piece of generated diagnostic information. You should view every flow volume loop, body plethysmography measurement, and patient identification detail as protected data that requires strict access protocols. Even in casual settings within the laboratory, discussing specific patient cases without necessity is a breach of security and professional decorum. Electronic health records must be shielded from unauthorized viewing, and you must ensure that your session is locked or terminated when leaving your workstation. This vigilance also extends to the physical storage of test results and the disposal of paper-based documentation that might contain identifiable information. Consistent adherence to these privacy rules minimizes the risk of unauthorized disclosure and protects the laboratory from significant regulatory penalties. Handling instances of physical distress or adverse events requires you to balance immediate life-saving care with accurate reporting. If a patient experiences a cardiac event or severe respiratory distress during testing, your first priority is the suspension of the procedure and the initiation of established emergency protocols. Once the patient is stabilized, you have an ethical obligation to document exactly what transpired, including the timing of the event and the specific test intervention that preceded it. This documentation must remain objective and thorough to protect all parties involved during the subsequent investigation of the mishap. Transparent reporting is not an admission of error. Rather, it is a necessary component of high-quality laboratory oversight and continuous safety improvement. By analyzing these critical incidents, you contribute to the overall refinement of testing safety protocols across the entire institution. The ethical imperative becomes even more pronounced when you encounter patients with cognitive or communication impairments. In these situations, you must adjust your instructional techniques without compromising the integrity of the diagnostic maneuvers or the standardization of the test. If a patient cannot provide meaningful consent or follow complex instructions due to cognitive decline, you must involve their designated legal guardian or power of attorney. Do not underestimate the need for patience, as you must verify that the patient is fully aware of what is required to produce a valid test result. Failing to account for these impairments can lead not only to incorrect interpretations by the physician, but also to significant trauma for the patient who is struggling to meet unrealistic expectations. Your role is to be a bridge between the clinical requirements of the test and the unique needs of the individual patient in front of you. I look forward to our next clinical discussion. Welcome to the Integrated Case Studies chapter, where we will synthesize our knowledge by analyzing comprehensive, longitudinal datasets. This chapter is designed to bridge the gap between theoretical calculations and the reality of clinical decision-making. When we approach a clinical case with multi-year data, it is rarely as clean as the textbook samples we encounter early in our training. Patients often return for serial testing over many years, and our primary duty is to discern between genuine physiological progression and technical variability. To assess therapeutic success, one must look closely at the baseline values established during the initial assessment and compare them against subsequent findings. If a patient shows a sudden, significant change in their forced vital capacity or diffusing capacity that does not correlate with their clinical presentation, your first instinct should be to audit the testing hardware and environmental variables from that specific window of time. Consistent monitoring allows us to distinguish between a transient measurement error, perhaps caused by suboptimal calibration or patient effort, and a true decline in pulmonary function. You are looking for trends, and trends are revealed by the stability of measurements over time, not by singular, isolated data points that might skew your diagnostic conclusion. Reconciling conflicting metabolic and mechanical data is perhaps the most challenging aspect of advanced pulmonary diagnostics. You might find a scenario where the mechanical measurements, such as those derived from body plethysmography, suggest a pattern that seems incongruent with the blood gas parameters or exercise capacity of the patient. In these instances, do not simply discard the outlier. Instead, investigate the physiological mechanism that could logically bind these two disparate findings together. For example, severe hyperinflation or air trapping can significantly mask restrictive patterns, and failing to account for the increased work of breathing might lead to a misdiagnosis. Always evaluate the consistency of the entire data set against the predicted values for that specific patient demographics, weight, and height. If the raw data segments are pulling in different directions, ask yourself if a technical failure occurred during the capture of the gas analysis, or if the patient's ventilation-perfusion mismatch is the culprit. Formulating these holistic conclusions requires a level of diagnostic reasoning that goes beyond just identifying an obstruction or restriction. When preparing findings for a multidisciplinary clinical review, you must be capable of articulating why the data points support a specific clinical diagnosis while addressing the inherent limitations of the equipment used. This is where your ability to communicate effectively with other specialists becomes valuable, as you need to translate technical instrument metrics into actionable clinical information. A surgeon or a pulmonologist does not need an explanation of how a turbine flow sensor operates. They need to know if the patient's functional lung volume is compromised and how the recent bronchial provocation testing impacts their surgical risk. Your role is that of a translator and a clinical sentinel who identifies when an error has occurred or when a patient's health trajectory has shifted. By mastering this integration, you ensure that the laboratory output becomes a central pillar of patient care rather than just a collection of numerical reports. See you in the next lecture. Welcome back. In this final session, we will synthesize our knowledge into a pragmatic strategy for tackling the RPFT examination. Successfully navigating the NBRC board exam requires more than just raw clinical knowledge. It demands a structured approach to the multiple-choice format. You have spent significant time mastering gas exchange, instrumentation, and pathology, but now we must focus on the mechanics of the test itself. Many candidates fail not because they lack understanding, but because they struggle to dissect the clinical matrices presented in complex questions. When you encounter a scenario involving conflicting pulmonary data, your first step should be to identify the primary physiological perturbation versus the secondary laboratory artifact. Distractors are specifically designed to lead you toward common assumptions, such as misinterpreting an obstructive defect as a restrictive one based solely on a singular flow volume loop. By stripping away extraneous clinical history, you can isolate the core diagnostic conflict and apply the appropriate decision-making framework we have built throughout this course. Training your mind to ignore redundant information will allow you to allocate your mental energy toward the parameters that actually determine the correct answer. Managing your time during the 2-hour examination window is a critical component of your success. You must develop a rhythm that allows you to address high-complexity cases without lingering too long on single-answer recall questions. If you find yourself spending more than 90 seconds on a complex clinical vignette, flag the item and move forward immediately to ensure you complete the entire bank. Returning to a difficult problem with a fresh perspective often reveals a subtle detail, such as an acid-base trend or a subtle drop in diffusing capacity that you initially overlooked. Avoid the temptation to change your answers unless you discover a distinct reason for the switch, as your initial intuition is often backed by the foundational knowledge you have reinforced in this curriculum. This approach minimizes the risk of losing time on items that carry the same weight as the simpler questions you can resolve in seconds. To finalize your preparation, you should utilize official practice exam data to perform a gap analysis on your remaining weak areas. Look for patterns in your errors, specifically identifying if you struggle more with technical instrumentation troubleshooting or the interpretation of advanced cardiopulmonary exercise testing results. Once you identify these specific domains, revisit the corresponding sections of our course to reinforce those mental models. It is more effective to devote your final hours to high-yield topics where you consistently lose points rather than reviewing material you have already mastered. Ensure that your final review includes a clear understanding of the regulatory and ethical frameworks that govern the laboratory environment, as these are often overlooked but represent consistent testable content. By tracking your progress through these practice sets, you will gain the confidence necessary to maintain your focus under the pressure of the live environment. Beyond the technical exam, remember that the RPFT credential requires ongoing maintenance through periodic documentation of professional development. Once you successfully pass the exam, your focus shifts toward organizational compliance and the standard of care in your daily practice. Familiarize yourself early with the renewal timelines and state-specific regulatory requirements that govern your licensure, as this ensures your career progression remains uninterrupted. Viewing the exam as one step in a wider professional framework will help you approach the test with a balanced, objective mindset. You have the tools, the strategy, and the clinical foundation to succeed. I will see you after you have conquered the exam.